please continue.
Okay, thank you. A 45-year-old man presents to the general practitioner with a 3-month history of generalized edema and frothy urine. He has a history of hypertension and a recent diagnosis of poorly controlled type 2 diabetes mellitus. His BMI is 35. Urine analysis reveals heavy proteinuria. What is the most likely diagnosis?
I think focal and segmental glomerulosclerosis.
So what is the most likely diagnosis?
I think diabetic nephropathy.
Most likely nephrotic syndrome, maybe secondary focal and segmental glomerulosclerosis.
So this patient has comes up with the features of nephrotic syndrome. We are having the 3 months history of generalized edema for the urine, as well as the heavy proteinuria on the dipstick. So these are the classical nephrotic picture. And with respect to the risk profile, the patient is having the BMI 35 kg per meter square, pointing towards the obesity or somewhat around the morbid obesity, as well as the hypertension. And usually the obesity as well as the systemic disease like the hypertension, they have the strong association with the secondary hyperfiltration, which is commonly seen in case of FSGS, focal segmental glomerulosclerosis. So both FSGS as well as the membranous nephropathy, both of them usually comes up with the features of nephrotic syndrome and the obesity as well as the hypertension, especially the obesity. This is strongly linked with the FSGS, and obesity is rarely linked with the membranous nephropathy. And also this patient's diabetes, this is recent and this is also poorly controlled. So this is too short to explain the sudden heavy proteinuria via the classical diabetic nephropathy. So most likely this is a case. Also with respect to the pathophysiology of FSGS, so usually in case of obesity there is glomerular hyperfiltration as well as the segmental sclerosis in some of the glomeruli, which ultimately leads to the non-selective heavy proteinuria as well as the edema. And with respect to the association, so what are the conditions that are commonly associated with the FSGS? Can anyone tell me the condition commonly associated with FSGS? One is the HIV, the HIV infection. Another one is the heroin use. So we have the HIV, we have the heroin. And with respect to the infective condition like the hepatitis B virus and C virus, they're usually commonly related to the other variant with the membranous nephropathy. And remember this very carefully, the obesity is strongly linked with the FSGS. The obesity rarely comes up with the membranous nephropathy, and also the systemic disease like the diabetes as well as the hypertension. They are also closely related to the FSGS. And diabetes is also related to the diabetic nephropathy. But in case of diabetic nephropathy, the diabetes should be long-standing, usually at least 10 years. So how to treat a case of FSGS?
Steroid immunosuppression.
So at first you need to start with the ACE inhibitor or ARB. You can either start with ACE inhibitor or you can start with the ARB to reduce the intraglomerular pressure as well as the proteinuria. So what should be the biopsy findings in case of FSGS? What should be the biopsy findings? The clue is within the name. There would be focal
sclerosis.
Yes, there would be focal and segmental sclerosis. And also there should be deposition of IgM or C3 within the sclerosed segment. And in some of the cases, if you go for the electron microscopy, then you can also see the podocyte food process effacement as a part of the nephrotic syndrome. So in case of diabetic nephropathy, typically it will require the years of diabetes, and it usually starts with the microalbuminuria, which will ultimately progress towards the overt proteinuria, and in most of the cases diabetic nephropathy, it will coexist with the diabetic retinopathy. So what should be the biopsy findings in case of diabetic retinopathy? This is very important. Which one is the hallmark biopsy findings?
الفيلشتاين
essential hyperpronation.
تلقى
This is known
في
as
الديابيتك نفروباتي تلقى كلمة
Kymel-Still
كلمة
Wilson's
شاين
lesion.
نديول
Okay, there would be Kymel-Still Wilson's lesion in the form of nodular glomerulosclerosis, and there can also be hyaline arteriosclerosis. So this one is the hallmark features. The Kymel-Still Wilson's lesion coming up as a part of nodular glomerulosclerosis. This is the hallmark biopsy findings. This is the hallmark histological findings in case of diabetic nephropathy. So this one is very important. This comes very frequently in the exam. And in case of IgA nephropathy, so this is also known as the synpharyngitic nephritis. So they will come up with the nephritic presentation. So patient will have macroscopic hematuria within 1 to 2 days following the upper respiratory tract infection. It can be associated with proteinuria. It may not be associated with proteinuria, and typically it will have the nephritic presentation. But here we are getting the nephrotic presentation. And also the membranous nephropathy. Membranous nephropathy also comes up with the features of nephrotic syndrome. So it can either be idiopathic, which is related to the anti-PLA2
phospholipase
antibody,
A2
or it can be associated with a long list of conditions, especially the drugs as well as the infective condition. So what are the infective conditions that are commonly associated with membranous nephropathy?
hepatitis B you see
And syphilis.
Which one is more?
hepatitis B
Yes, very good. So hepatitis B, this is more common. So in most usually in your part 1 exam, in most of the cases, most frequently they will give you the malignancy. For part 1, most likely they give the malignancy, and in case they don't give you the malignancy association, you need to look for the infective condition. So hepatitis B, hepatitis C, syphilis, and malaria, and they will predominantly have the nephrotic syndrome type of picture. So how to treat a case of membranous glomerulonephritis? Stepwise treatment.
is inhibitor steroid immunosuppression.
So we have the two variant. One of them is the idiopathic membranous nephropathy. Another one is the typical. Typical means there should be associated cause, either malignancy or other infective cause or other association. If there is no cause, and if this is associated with anti-PLA2 antibody, this is the idiopathic. So the treatment protocol is slightly different in between idiopathic versus the typical. So how to treat a case of idiopathic membranous nephropathy?
Transfusion inhibitor.
So in case of idiopathic, you need to remember 4C, and in case of typical variant, you need to remember 2C. So if this is typical variant, you should go for combination of 2C, corticosteroid plus cyclophosphamide, because the typical variant usually comes up with the features of RPGN, usually comes up with the features of severe presentation. So in the typical variant, we usually go with combination of 2C, corticosteroid plus cyclophosphamide. And in case of idiopathic variant, we need to go in a stepwise fashion. So at first, we'll be starting with the ACE inhibitor or ARBs, followed by the 4C. So number 1 would be anti-CD20, also known as Rituximab. No response, go for calcineurin inhibitors like cyclosporine. No response, go for combination of 2C. So for idiopathic variant, for the typical variant, you can directly go for 2C combination. But in case of idiopathic variant, you need to go in a stepwise. Rituximab, no response. Cyclosporine, no response. Corticosteroid plus cyclophosphamide. And also there is another drug, chlorambucil. It can also be used, but this is less important. So you can forget. You can simply remember these 4 conditions, these 4 drugs. And
Doctor,
last
can
one
you
is our
differentiate between
any
and
question?
idiopathic? Can you differentiate between the idiopathic and typical?
So in case of idiopathic, there should be no associated cause, and they will clearly tell you this is related to anti-phospholipase A2 antibody. Okay, this antibody would be positive. There should be no cause, and we know that the membranous nephropathy has a long list of causes. So especially malignancy, or if this type of cause is associated, this is our secondary. So if an etiology is there, this is secondary, this is typical. If there is no etiology, this is related to antibody, this is our idiopathic variant. And last one is our minimal change disease. So it will also comes up with the features of nephrotic syndrome, but this is usually seen more commonly in the children, or it can come up as a part of NSAIDs or Hodgkin's lymphoma. And usually in case of MCD, the patient are usually normotensive, and the obesity, this is not also linked with the minimal change disease. Focal and segmental glomerulosclerosis is most likely in this patient given his presentation with a heavy proteinuria. FSGS is a common cause of nephrotic syndrome in adult and is often associated with obesity, especially the morbid obesity. So whenever obesity is there along with nephrotic syndrome, you should always consider it as an FSGS. Systemic disease such as hypertension and diabetes, which are both present in this patient. The diagnosis is supported by the clinical pictures of generalized edema for the urine and the findings on urine analysis. Histologically, FSGS is characterized by sclerosis in some but not all the glomeruli. That's why this is known as the focal protein leakage. And in case of diabetic nephropathy, usually this is slow, there will be gradual onset, and usually there should be long-standing uncontrolled diabetes. And this is the hallmark feature, Kymel-Stein-Wilson's lesion. It will show nodular glomerulosclerosis. This is our synpharyngitic macroscopic hematuria within 1 to 2 days of the upper respiratory tract infection. Membranous is either related to antibody or there should be associated malignancy or infective condition. This is rarely associated with the obesity, and MCD will occur in the children. Okay, next one please.
A 63-year-old woman presents to the emergency department with worsening shortness of breath while taking bronchodilators over the past few months. She is a non-smoker and her pulmonary function tests reveal a forced expiratory volume in 1 second of 1.29 to 1.35 liters and an FVC of 2.95 to 3.45 liters. Which of the following is the most likely cause of her symptoms?
Also, listen to this very carefully. Whenever you encounter the pulmonary function test or spirometry interpretation in your exam, the step 1 would be calculation of FEV1 versus FVC ratio to differentiate obstructive from the restrictive lung defect. If this is obstructive lung defect, then the next step would be whether this is fixed or whether this is reversible airway obstruction. So which one is a classically reversible obstructive airway disease?
Asthma.
Yes, very good. This is our bronchial asthma. This is our bronchial asthma. Bronchial asthma is the classically reversible obstructive lung disease. So what can be the most likely cause of our symptoms? So this patient is having the symptoms despite using the bronchodilator over months. So this is suggestive of fixed rather than reversible obstruction. The patient is a non-smoker. The patient is a non-smoker, so COPD is less likely unless there is other associated alpha-1 antitrypsin deficiency. And if we analyze the spirometry, so 1.3, something around 3, so it should be somewhat around 0.5. So this is our obstructive lung defect, and since there is minimal changes across the repeated testing, so this indicates there is no bronchodilator reversibility. So can anyone tell me the criteria of bronchodilator reversibility? What should be the increase in FEV1 in terms of
البرونكوديليتور ريفرسبيليتي بالنسبه للازمه يبدا بوزيتيف ريفرسبيليتي more than 12% or more than 200 مل. هذا
yes,
بالنسبه
so
للبرونكيال
it
ازمه.
should be either the rise in FEV1 following bronchodilator, it should be either greater or equal to 12%, or it should be greater or equal to 200 ml. So if any of the criteria fulfills, this indicates the bronchodilator reversibility testing is positive. So here we are getting somewhat like the this is our fixed obstructive airway defect. So most likely this is our bronchial stenosis. Bronchial stenosis is one of the fixed large airway obstruction. So in case of fixed airway narrowing, usually it can be either stenosis, or it can be post-intubation, or it can be the post-TB scarring, or in some cases the endobronchial lesion or the benign stricture. They usually produces the persistent obstruction, and they will not improve with the inhaled bronchodilator. And the spirometric pattern here is showing the obstructive pattern with a relatively preserved FVC ratio and a stable FEV1 following the bronchodilator. And usually in case of fixed large airway obstruction, there would be flattening of the both inspiratory as well as the expiratory limb within the flow lobe volume. And so how to treat a case of bronchial stenosis? Treatment. So the initial management would be either dilatation or stenting. If there is failure, then the next step would be the surgical procedure. So with respect to asthma, we'll get the typically reversible obstruction. So following the bronchodilation, the FEV1 will either increase greater or equal to 12% or greater or equal to 200 ml. And in case of COPD, this is strongly linked to smoking, or it should be linked to the alpha-1 antitrypsin deficiency. In case of interstitial lung disease, so it will shows the restrictive pattern. So there would be low FVC, and there would be either normal or high FEV1 FVC ratio, usually greater than 0.7 or greater than 0.8. And with respect to pulmonary embolism, this is something related to the ventilation perfusion problem. So there would be normal spirometry, and it should be either it will have either acute presentation or subacute presentation, presenting with the shortness of breath, pleuritic chest pain, tachycardia, as well as the hypoxia. And here we are getting the chronic condition. So whenever you find obstructive pattern, no bronchodilator response, non-smoker, you should always first think of the fixed large airway obstruction like the bronchial stenosis. And with respect to reversibility criteria, you need to memorize FEV1 greater or equal to 12% or greater or equal to 200 ml, which is classically seen in case of asthma. Bronchial stenosis, narrowing of the airways, can cause fixed airway obstruction. This is reflected in the patient's pulmonary function test, which show a consistent low FEV1 with a relatively preserved FVC. This reduces the FEV1 FVC ratio, indicative of obstructive lung disease that does not significantly improve with the bronchodilator. Unlike asthma and COPD, bronchial stenosis does not typically vary with the treatment, explaining the patient's persistent symptoms despite the inhaled bronchodilator. This fixed obstruction pattern is most consistent with the findings described. Asthma typically presents with the episodic symptoms of wheezing, breathlessness, chest tightness, coughing, particularly at night or in the early morning. Pulmonary function tests in asthma usually show reversible airway obstruction. So COPD will either have the smoking history or significant exposure to lung irritant, and this is usually progressive with the partially reversible airflow obstruction. and ILD will have the restrictive lung defect. Pulmonary embolism will have either acute or subacute presentation with normal spirometry, and there should be shortness of breath, chest pain, tachypnea, and the hypoxia.
What are the other causes of fixed obstruction, doctor? Can you say?
It can be post-intubation, or it can be stenosis, it can be post-TB scarring, it can be benign stricture, or it can be the endobronchial lesions.
Okay, thank you.
Okay, next.
A 45-year-old woman presents to the general practitioner with complaints of progressive skin thickening on her fingers and face and difficulty swallowing over the past several months. She also mentions experiencing Raynaud's phenomenon and joint pain. On examination, there is evidence of sclerodactyly and telangiectasia.
So most likely diagnosis.
Crest.
So you're
Systemic
having the
sclerosis.
crest features. So most likely this is our systemic sclerosis. So patient is having the progressive skin thickening of the fingers and the face. So these are the classical clues in favor of the scleroderma. And this sclerodactyly, this is highly specific for the systemic sclerosis, and this difficulty swallowing, this is due to the esophageal dysmotility, and this is also common in case of systemic sclerosis as a part of crest features. And Raynaud's phenomenon and telangiectasia, these are also the classical features of crest syndrome, especially in the limited cutaneous subtype. And with respect to the joint pain, so this often overlap, although this is not the dominant features. So this so all the clinical hallmark, all the clinical hallmark of skin thickening due to the excessive collagen deposition leading to sclerodactyly and mask-like fascia, as well as the vascular features like Raynaud's phenomenon, telangiectasia, as well as the digital ulceration and the GIT involvement like esophageal dysmotility, reflux, or dysphagia. These are usually the typical condition, typical presentations of systemic sclerosis. So with respect to systemic sclerosis, we have the limited cutaneous, we have the diffuse systemic sclerosis. So the scleroderma renal crisis, this is more common in which condition? And pulmonary hypertension is more common in which condition? I mean, which subtype? Scleroderma renal crisis, this is more common in diffuse, or this is more common in limited variant?
I think
both of them.
Diffuse
And
variants.
pulmonary hypertension,
Limited
Limited.
variants.
this is more common. 1 minute.
I think interstitial lung disease more common
Yes,
in
the lung involvement, the lung
yeah.
involvement, especially the internal
Pastest.
lung involvement. This is classically seen in case of diffuse variant. So remember,
diffuse.
the scleroderma renal crisis, this is more common in case of diffuse variant. Pulmonary fibrosis, meaning the internal organs, especially the lung involvement, this is more common in diffuse cutaneous systemic sclerosis. And usually the students get confused whenever pulmonary hypertension is asked. So remember, pulmonary hypertension, this is related to the limited cutaneous, and we can easily differentiate with respect to the skin involvement. We'll start distally, and then afterwards it will progress centrally. So if the skin thickening is just distal to knees and elbows, this is our limited cutaneous. And if this extends towards the central, so if this is proximal, meaning whenever the upper limb is involved, or whenever the chest is involved, or the back of the chest is involved, this is regarded as the diffuse variant. And the face may be involved in either of the types. So facial involvement, this is not a good differentiating point. And also you can differentiate using the antibodies. So diffuse is related to anti-SCL70. This is also known as topoisomerase 1. This is classically seen. Other than topoisomerase 1, there is another one known as the RNA polymerase 3 antibody. This is also seen in case of diffuse variant. And limited cuteness, this is related to the anti-centromere antibody. And usually the CREST syndrome. CREST syndrome is classically associated with the limited cutaneous. But whenever the CREST syndrome is associated with the internal organ, meaning the lung involvement like the pulmonary fibrosis, then it will again falls under the diffuse variant. So isolated CREST, no lung involvement, no pulmonary fibrosis. This is our limited variant. Features of CREST plus pulmonary fibrosis. This is our diffuse variant. So what should be the presentation in dermatomyositis?
Skin involvement, heliotropic rash,
So there should be the features
uncoated.
of proximal muscle weakness or proximal myopathy, or simply you can say there should be features of PMR plus there should be dermatological involvement. So either there can be heliotrope rash or there can be Gottron's papule. In case of MCTD, there would be overlapping features of systemic sclerosis plus polymyositis plus SLE. But here all the presentation, they are very classical for the systemic sclerosis. There is no overlapping. In case of MCTD, which antibodies would be positive?
RND.
Yes, anti-U1 RNP antibody. And rheumatoid arthritis.
URMP.
Rheumatoid arthritis is in case of RA, there should be chronic symmetrical polyarthritis of the small joints of hands and feet. There can be extra-articular manifestation, but the skin thickening or Raynaud's phenomenon, they are usually never seen in case of rheumatoid arthritis. And in case of SLE, usually there can be malar rash, arthritis, serositis, photosensitivity, as well as the renal disease. So whenever there is a triad of sclerodactyly, Raynaud's, esophageal dysmotility, this is the systemic sclerosis until proven otherwise. And based on the antibody or based on the organ involvement, or you can easily differentiate whether this is limited cutaneous or whether this is diffuse subtype. Systemic sclerosis is characterized by progressive skin thickening, meaning the sclerodactyly internal organ involvement. Common features include Raynaud's phenomenon, esophageal dysmotility, which can lead to difficulty swallowing, and telangiectasia. The combination of these symptoms with these physical findings described in the vignette makes systemic sclerosis the most likely diagnosis. Systemic sclerosis can also involve other organ systems such as the lung. Dermatomyositis is an inflammatory myopathy characterized by proximal muscle weakness and a distinctive heliotrope rash. While skin manifestations are present, they usually do not typically include sclerodactyly, telangiectasia, or Raynaud's phenomenon. So MCTD will have the overlapping features. SLE plus SC plus polymyositis related to anti-U1 RNP antibody. In case of RA, there should be symmetrical polyarthritis of the small joints of hands and feet. And SLE will have the multisystemic involvement. Okay, next.
A 72-year-old woman presents to the emergency department with complaints of feeling insects crawling on her skin and experiencing suicidal thoughts for 3 weeks. Her relative denies any history of substance abuse or recent travel. Her medical history includes hypertension, type 2 diabetes, and osteoarthritis. What is the most likely diagnosis?
P. Depression and psychotic features.
So we are having the 72 years old woman with a 3 weeks course. So this is somewhat related to the subacute course. So late life new onset psychosis, this is usually the affective disorder. This is rarely the schizophrenia. And with respect to the suicidal thought, so this points towards the severe
Psychotic
depressive
features.
episode. This points towards the severe depressive episode. And we are also having the tactile insect crawling sensation, and as well as the somatic preoccupation. So it can occur as a part of mood congruent psychotic phenomenon, which is commonly seen in case of psychotic depression, also known as the depression with the psychotic features. And since there is no substance history, no travel, no fluctuating consciousness, so this is pointing against the substance induced psychosis as well as the delirium. And also, since the duration is less than 3 months, so this is also pointing against the persistent delusional disorders. So usually the this psychotic depression, this is commonly seen in the older adult, which usually comes up with the features of severe low mood, suicidability, as well as the nihilistic psychotic symptoms like the infestation or serious illness. And also this subacute onset with the suicidal ideation, as well as the somatic or tactile psychosis. So this fits best with the depression with the psychotic features. And usually the schizophrenia, this usually occurs very early within the life, and there would be prolonged course. So how to manage a case of psychotic depression? Management, treatment. How to treat a case of psychotic depression? We are having psychotic component, we are having depressive component. So you need to go for combination of both antidepressant plus antipsychotics. Okay, so in psychotic depression, meaning major depression with psychosis, there may be hallucination, typically accusing or derogatory voice. So MDD may present with the psychomotor retardation, typical vegetative symptoms like either anorexia, weight loss, insomnia, particularly early morning awakening, and the psychotic symptoms like delusion or hallucination, or there can also be the tactile efforts. So the first line would be combination of antidepressant plus antipsychotics. No response, go for the ECT, electroconvulsive therapy. So there would be vegetative symptoms, there should be psychotic symptoms. Both of the components should be simultaneously present in case of psychotic depression, also known as MDD with the psychosis. And in case of paranoid schizophrenia, this is dominated by the relatively stable, often paranoid delusion, usually accompanied by hallucination, particularly of the auditory. In case of delirium, there should be a very acute onset, like within hours or within days, and there should be either fluctuating attention or there should be fluctuating awareness. And paranoid schizophrenia, so it will typically begins very earlier, usually the late teenagers. Please mute yourself. From the late teenagers up to somewhat around 35 years or 40 years. And it should be also the nature would be chronic, at least greater than 6 months. Persistent delusional disorder, so this is also known as the delusional parasitosis or egg bombs phenomenon. So classically there would be a single system delusion, most commonly the infestation, and there should be relatively preserved affect as well as the functioning, and again the duration should be prolonged. It must be greater than 3 months. And in case of substance induced psychosis, there should be the history of the substance abuse. Depression with the psychotic features or psychotic depression can present with the mood congruent delusion. Remember, psychotic depression will have the mood congruent disorder. Schizophrenia will have the mood incongruent disorder, such as feeling of worthlessness or guilt, or in this case somatic delusion of insect crawling on the skin. The presence of suicidal thoughts further supports the diagnosis of severe depressive episode. Her age and lack of substance use history also make this diagnosis more likely than other psychiatric condition. And delirium, it should be a very acute onset of fluctuating consciousness, disorientation, or cognitive impairment. and paranoid schizophrenia. So this is more commonly seen in the teenagers. There should be persistent delusion along with the auditory hallucination. Persistent delusional disorders also persistent at least greater than 3 months. And substance-induced psychosis. So within the history, there should be either something related to the drug abuse or alcohol abuse or other substance history. Okay, next.
Okay, a 34-year-old woman presents to the emergency department with a headache, fever, neck stiffness, and photophobia. Her past medical history is significant for a documented penicillin allergy causing anaphylaxis. CSF analysis indicates bacterial meningitis. What is the most appropriate antibiotic treatment for this patient?
Chloramphenicol.
So bacterial meningitis with
Chloramphenicol.
anaphylactic reaction to penicillin. So what should be the most likely treatment?
Chloramphenicol.
Yes, we need to go for the chloramphenicol. Also meningitis plus history of anaphylaxis to penicillin or penicillin allergic patient, go for the chloramphenicol. So how to treat a case of pneumococcal meningitis and how to treat a case of Listeria meningitis? Someone tell me the treatment of all types of meningitis. This is very important for the exam.
Listeria meningitis, الأموكسيسيلين والإمبيسيلين جنتاميسين.
And usually penicillin plus gentamicin, if listeria.
Also streptococcal or pneumococcal, go for combination of 2 drugs, ceftriaxone plus vancomycin. Whenever there is associated purpuric rash, this is our meningococcal meningitis. Whenever rash is there, you need to go for single drug with the ceftriaxone. Prophylaxis is required whenever there is a rash. With respect to the prophylaxis, commonly we go for the ciprofloxacin. You can also go for the ofloxacin. No prophylaxis is needed for the pneumococcal meningitis. And with respect to Listeria meningitis, remember very carefully. So ceftriaxone is used in all types of meningitis except Listeria. Listeria meningitis don't respond to the ceftriaxone. Alternatively, you need to go for combination of ampicillin. You need to go for gentamicin plus either amoxicillin or ampicillin. And with respect to the Listeria, you need to look for the clues. Like there should be either history of taking the cheese or travel to the France, or they are commonly related to the pregnant women. Other than this, this is also seen in case of elderly. This is seen in case of neonate, especially up to 5 years, or it can be seen in case of immunocompromised patient. So usually either elderly patient or neonate or immunocompromised or pregnant lady or eating the French cheese with raised CRP, CSF lymphocytosis with the features of meningism. Consider it as an Listeria meningitis. So go for combination of gentamicin plus either amoxicillin or ampicillin. Or in some of the scenarios, they will give you the features of meningism and the patient was being treated with ceftriaxone. No response. So this is also a clue in favor of Listeria meningitis.
I think in Listeria, the highest group given cotrimazole.
Sorry, repeat please. I can't understand your statement clearly.
I asked the Listeria meningitis, especially في الهاي ريسك يعني في الالدرلي او في البريجننت وومن او في immunocompromised. You can
actually,
the
doctor, your voice is breaking. You can kindly type here. I will get back to you. You can type here on the chat box.
Okay.
Chloramphenicol is the most appropriate antibiotic treatment for a patient with a bacterial meningitis and a documented anaphylactic reaction to penicillin. This is a broad spectrum antibiotics effective against many types of bacteria causing the meningitis. It can penetrate the CNS as achieving the therapeutic concentration in the CSF. And ceftriaxone, since there is history of anaphylaxis to penicillin, so it would be advisable also to avoid the cephalosporin in order to avoid the cross reactivity. And clindamycin does not cross the blood-brain barrier. Doxycycline is not indicated. And vancomycin is usually indicated whenever the streptococcal, meaning the pneumococcal, this variant is suspected. And also in the original recall, it was almost similar types of scenario, and it was also the clear cut. Low sorry. Low a young patient presenting with a fever, neck stiffness. Mother reported he has history of severe penicillin allergy when previously treated for the tonsillitis. Treatment of choice would be the chloram allergic reaction. You should go for the chloramphenicol. So broad spectrum antibiotic that is effective against many of the common causative organisms of bacterial meningitis, including Streptococcus pneumoniae and the Neisseria meningitis. It's an appropriate choice for patient with a penicillin allergy because it does not share the same allergy risk as penicillin. This is a safe alternative when penicillin or cephalosporin are contraindicated. Okay, next.
A 57-year-old woman presents to the general practitioner with progressive dysphagia and a history of recurrent aspiration pneumonia. She has been diagnosed with a motor neuron disease and her condition is deteriorating, making oral feeding increasingly difficult. What is the most appropriate method of providing nutritional support for this patient?
Endoscopic gastrectomy.
Also, we need to go for the PEG, percutaneous endoscopic gastrostomy. So here our diagnosis is the motor neuron disease. This is one of the progressive neurodegenerative disorder which usually affects the bulbar muscle, and usually the patient will come up with the features of dysphagia as well as there is chance of recurrent aspiration pneumonia. So the oral intake would be no longer safe in those type of patient, and usually this type of patient will need the long-term nutritional support. So this MND patient, they usually benefit from the PEG insertion before the severe respiratory compromisation already occurs. So this PEG, it will provide the direct access to the stomach by bypassing the oropharynx. So there is a reduced chance of aspiration risk, and this is also suitable for the long-term feeding in all the neurodegenerative disease, like either in MND or stroke, or in case of advanced multiple sclerosis. And this is also more comfortable as well as the sustainable than the repeated NG tube feeding. And with respect to the ileostomy, so this is something a stoma that is to divert the bowel content. This is not a feeding route, and this is usually used in a bowel disease, like in case of Crohn's disease, or in case of cancer patient, or in case of perforation. With respect to the NG tube, so this is usually useful for the short-term feeding, meaning less than 1 month, like less than 4 to 6 weeks. And in case of MND, you need to go for the long-term feeding, and also there is high aspiration risk. And in case of NG tube feeding, there is chance of gastric reflux. The persistent gastric reflux, it can lead to the aspiration. So this is not also suitable for the long-term feeding in case of MND. With respect to the nasoduodenal tube, so it can reduce aspiration compared to the NG tube, but this is also suitable for the short-term feeding. This is not suitable for the long-term. And the TPN, so TPN is given in the IV route bypassing the gut, and this is usually reserved for the intestinal failure, or whenever the enteral feeding is impossible. And this TPN, it also carries the risk of line sepsis or hepatic dysfunction, as well as the electrolyte imbalance. So whenever there is MND associated with dysphagia with or without increased chance of aspiration, the most suitable one would be the PEG feeding. And NG tube is for the short term, PEG is for the long term, and whenever the gut cannot be used, you should go for the TPN. So always remember, in case of progressive neurological dysphagia, especially in case of MND, for long-term control, you should always go for the percutaneous endoscopic gastrostomy. So PEG is the most appropriate method for providing the long-term nutritional support to a patient with MND who has a difficulty swallowing or is at a risk of aspiration. PEG tubes allow direct access to the stomach for feeding, reducing the risk of aspiration compared to the oral as well as the nasogastric feeding. So I'll estimate this is suitable following the surgery. NC tube, this is for short term. There is chance of displacement, there is chance of aspiration. And TPN carries the chance of metabolic complication, hepatic dysfunction, as well as the increased chance of line sepsis. And in the original recall, the scenario was almost similar, but the options were slightly different. So MND having the dysphagia, long-term feeding technique, nasogastric tube, nasojejunal tube, percutaneous nasogastric tube, percutaneous nasojejunal tube. So we'll be going for the percutaneous nasogastric tube. So MND, this usually leads to the progressive muscle weakness, dysphagia, often resulting in difficulties with the oral feeding, and patient usually requires a solution to support adequate nutrition for the long term due to inability to swallow safely. And dysphagia is also a common complication in MND as the muscles controlling the swallowing is weakened over time. So this PEG difficulties so requires nutritional support. It is placed directly into the stomach through the abdominal wall under endoscopic guidance, making it more comfortable and suitable for the long-term use than the nasogastric tube. PEG tubes are commonly used in MND patients with dysphagia as they are more secure and durable for long-term feeding compared to the other option. And NG tube, this is for short-term feeding. And with respect to nasojejunal tube, this is placed within through the nose into the jejunum, usually for patient with a delayed gastric emptying or gastric outlet obstruction. This is typically used for the short-term feeding. And the percutaneous nasojejunal tube, this is similar to nasojejunal tube but inserted through the skin rather than the nose. This is less common and this is used for specific condition that affects the gastric emptying or digestion. So here we are having the chart. So if you memorize this chart, then you'd be able to answer everything. So with respect to the NG tube, the nasogastric tube, so the route is from nose towards the stomach. This is suitable for short term. This is indicated in case of stroke with transient dysphagia or for the early nutritional support. And there is increased chance of aspiration risk, and there is chance of nasal or esophageal irritation. The nasoduodenal or nasojejunal tube, these are also indicated for the short term. So short term means less than 6 weeks, and if anything is needed over 1 month or over 6 weeks, this is regarded as the long term. So in case of NJ, so from nose to either duodenum or jejunum, there is also increased high aspiration risk. Whenever there is high aspiration risk, like in case of severe reflux or gastroparesis or pancreatitis, you can go for the nasojejunal tube. And this is also suitable for the short term. And this PEG, there would be directly access to the stomach via the abdominal wall. This is suitable for the long-term feeding in case of progressive neurodegenerative condition like the MND or advanced multiple sclerosis or stroke with the persistent dysphagia. And with respect to the complication, there can be insertion complication like the bleeding, infection, peritonitis. So aspiration is still possible, but the chance of aspiration is lowest in case of PEG, and this is contraindicated in severe respiratory compromise at the time of insertion. And the TPN you need to go for the IV central line. This is the duration should be variable, either short or long term, depending on the gut function, and this is suitable for the intestinal failure whenever there is short bowel or short bowel obstruction or severe malabsorption or fistula. And this is related to the central line sepsis, metabolic or electrolyte derangement, liver dysfunction are very expensive. So this point is very important. Always look at the duration. So short term, less than 6 weeks, go for nasogastric or nasojejunal. Whenever long term, just remember PEG. So MND, go for PEG. Okay, next.
A 58-year-old man presents to the emergency department with a history of progressive muscle weakness and bladder urge incontinence. She has been diagnosed with motor neuron disease and her symptoms have recently worsened. What is the most appropriate initial management for her bladder urge incontinence?
Oral tolterodine.
So they're asking regarding the management of the urge incontinence. So which one is the first line lifestyle modification in case of urge incontinence? Which one is
Intermittent catheterization.
No.
So they should or not? That's making the question more difficult.
With respect to so in case of stress incontinence, most probably you need to start with the pelvic floor exercise, right? Or I am saying the reverse.
Yes, right.
So in case of stress incontinence, probably we will start with the pelvic floor exercise. And in case of urge incontinence, we usually start with the bladder retraining. If there is no response, we need to go for the pharmacological therapy. So stress causes distress. So distress for the duloxetine. And in case of urge incontinence, we'll go for the anticholinergic drugs. Usually we start with either oxybutyrate or we start with the tolterodine. But if the patient is elderly patient, usually greater than 65 years, or if there is any features of confusion, then in that case we need to go for the mirabegron. Mirabegron is the beta-3 adrenergic receptor agonist. So here we are going for the tolterodine. For the urge incontinence, we need to go for the tolterodine. So this MND primarily, this is one of the motor dysfunction. But the bladder symptoms like the urge incontinence, it can occur due to the detrusor overactivity. So this urge incontinence occurs due to detrusor overactivity, and the uterine prolapse leading to abdominal pressure leads to the stress incontinence. So for stress incontinence, you should start with the pelvic floor exercise. In case of urge incontinence, you should start with the bladder retraining. And this tolterodine, this is our antimuscarinic selective for the bladder. It will reduces the detrusor overactivity, ultimately leading to the reduced urgency as well as the urge incontinence. And you can administer it as a part of oral route, and this is usually well tolerated. Intravesical.
So they are already give us. Sorry, sir. They are already give us the type of incontinence here, so we don't need for ultrasound and stuff like that, right?
So either in the scenario they will never ask something related to the ultrasound, or they will either directly mention regarding whether this is urge incontinence or this is stress incontinence. So either they will directly mention, alternatively they will give you the clinical features suggesting either urge incontinence or the stress incontinence. So either it would be directly mentioned, either or there should be clinical clues. There should be nothing, you don't need to be worried regarding the ultrasound. And then
Thank you.
intravesical botulinum toxin. So this is usually reserved for the refractory cases, for the detrus or overactivity whenever the medication fails. And this is one of the invasive procedure, and it will require the cytoscopic injection. And pelvic floor exercise, this is for the stress incontinence, which usually occurs in the postpartum patient or in the post-prostate surgery. Indwelling catheter and the intermittent catheterization, they are usually suitable whenever there is retention, whenever there is urinary retention, especially due to the neurogenic bladder. We go for the intermittent self catheterization. So whenever urge incontinence is there due to detrus or overactivity, then you should start with the oral antimuscarinic like the tolterodine or oxybutynin, or you can also go for the solifenacin. In the elderly case or in the confusion, you should go for the mirabackron. For stress incontinence, go for the pelvic floor exercise. For retention, urinary retention, go for intermittent catheterization. And refractory urge incontinence, you can go for intravesical botulinum toxin. So this is for the bladder urge incontinence in a patient with MND. Tolterodine is an antimuscarinic agent that reduces the bladder muscle contraction, thereby reducing the urinary frequency and urgency. And pelvic floor is for the stress incontinence. And whenever retention is there, go for the intermittent catheterization. So in the original recall, it was a little bit different scenario. So try this one.
This is urge incontinence, and then we give tolterodine.
Why should it be urge incontinence?
Because there is urinary frequency, and the patient is having occasional incontinence.
Neurogenic?
No,
So
I
number one,
think
this
there
is
is
one of the
residual.
neurogenic condition. The patient is having the secondary progressive multiple sclerosis. So this is one of the neurogenic condition. So most likely there would be neurogenic bladder, and the post maturation residual volume is 20 ml on the USG. So there is features of urinary retention. So urinary retention in case of
Intermittent
neurogenic condition.
self-catheterization.
So we need to go for the catheterization.
The
More
catheterization.
specifically the which one?
And for neurogenic bladder.
We need to go for suprapubic or intermittent.
Intermittent.
Yes, very good. We need to
Intermittent.
go for the intermittent self-catheterization. So whether this is MS, whether this is MND or other neurogenic condition leading to neurogenic bladder associated with the features of retention, there is residual volume, go for the catheterization, more specifically the intermittent self-catheterization, ISC. So secondary progressive multiple sclerosis often results in urinary symptoms such as frequency, incontinence and retention due to both central and peripheral nervous system involvement. The patient's post-maturation residual volume of 20 ml indicates some degree of urinary retention, which is likely contributing to our symptoms. And ISC is the recommended approach for managing urinary retention in MS patient. It allows for emptying of the bladder, can prevent complications like UTI or further bladder damage.
Sir, what is the normal post-void residue? Isn't it normal?
This is normal. This is normal, but here they are just giving the clues that this patient is having the neurogenic bladder, and there can be retention. This is just for the clues. We are considering that there is chance of retention, so we need to go for the intermittent self catheterization. Even if this is not mentioned, in case of neurogenic condition that are related to the neurogenic bladder, you need to go for the intermittent self catheterization.
Okay, thank you.
And with respect to suprapubic catheter, so this is considered if the intermittent self catheterization is not feasible or if the patient has persistent retention. However, the IC is generally preferred as it is less invasive and can be done on an OPD basis. So here is our urinary continence types and the typical causes as well as the first line management. So stress. So with respect to the stress, so this type of clinical features would be given, like there would be leakage following the coughing, laughing, sneezing, or even following the exercise. This is related to the weak pelvic floor or urethral sphincter incontinence leading to increased intra-abdominal pressure. So pelvic floor muscle training, this is the first line, followed by the duloxetine. Duloxetine, distress, stress. With respect to the urge incontinence, there should be sudden urge to void or leakage. There should be associated frequency, nocturia, and this is related to the detrusor overactivity. So first line would be bladder retraining, followed by the antimuscarinic, followed by the, or for the neurogenic condition, you need to go for the intermittent self catheterization, like in case of prostatic enlargement, diabetic neuropathy, spinal cord lesions, as well as the MND or advanced MS. And in case of mixed incontinence means there may be combination of both stress as well as the urge incontinence. In that case, you will treat the predominant component first. And in case of functional, so this is one of the diagnosis of exclusion. You need to address the underlying causes. So stress, pelvic floor first, urge, antimuscarinic, overflow, intermittent catheterization. In the mixed component, you need to treat the dominant component. So this is the stepwise algorithm. So stress, leakage on cough or sneezing, pelvic floor, followed by duloxetine, urge, sudden urgency, frequency and nocturia. Go for antimuscarinic or beta-3 adrenergic agonist. In case of mixed, you need to treat the dominant condition. And in case of overflow incontinence, go for the intermittent catheterization, or you can also go for the alpha receptor blocker for the bladder outlet obstruction, which is well seen in case of BPH. And in case of functional incontinence, you need to address the underlying cause. Okay, next.
A 63-year-old man presents to his general practitioner with fatigue, anorexia, and weight loss. Blood tests reveal microcytic anemia, and further investigation shows a mass in the stomach. In which phase of the cell cycle does DNA replication occur?
This.
So S is for synthesis. So DNA synthesis or DNA replication. The DNA replication will occur in the synthesis phase. So S is the synthesis phase of the cell cycle, and usually during the S phase, each of the chromosome, they will undergo the DNA replication. So the sister chromatid would be formed, which will ensure the daughter cell inheriting the identical genome. And also you need to remember the drugs, especially the cytotoxic drugs that target the S phase. And since they are targeting the S phase, so they will have the uncontrolled proliferation, like in case of gastric adenocarcinoma. So gastric adenocarcinoma, it will affect the S phase of the cell cycle. So what are the drugs? What are the drugs that are cytotoxic drugs that targets the S phase? Can anyone tell me? Usually the anti-metabolites like the 5-fluorouracil, methotrexate, as well as the
That's right.
hydroxyurea. So these groups of drugs, they usually target the S phase of the cell cycle. And the M phase, the mitosis phase, this is usually targeted by the vinca alkaloids,
Vincristine.
as well, yeah, the vincristine, as well as the taxanes, these groups of drugs. So
Taxane.
vincristine, remember very carefully, this one comes very frequently in the exam. So the vincristine acts on the M phase. It will act on the mitosis phase. So Z0, this is our resting phase. The cells will exit the cycle. And the G1, so G1, this is for the growth and preparation. So there would be cell growth, there would be protein synthesis, and there would be preparation for the DNA replication. The G2 is known as the gap2. So gap2 is our post replication checkpoint. There would be DNA repair and
Increase the
preparation
length.
for the
Increase the length of cycle.
mitosis. This G2 is known as post replication repair. And M phase is our mitosis, and S is our synthesis or DNA replication. The S phase or the synthesis phase is a part of cell cycle during which the DNA replication occurs. During this phase, each chromosome is duplicated to produce the two sister chromatid, ensuring that each daughter cell will have an identical set of genetic material followed by the cell division. The process of DNA replication is tightly regulated and critical for maintaining the genetic stability. This is the only phase of the cell cycle during which the DNA synthesis and replication takes place. So S is for synthesis, DNA synthesis, DNA replication. And the original recall was also similar, something like this. Phase. So it was almost identical. Scenario of a malignancy with chemotherapy drug is inhibiting the DNA replication. Which phase of the cell cycle DNA replication occurs? So this is our S phase, the synthesis phase. So this chart is also very important. Okay, C0, resting phase. The cells will exceed the cells exceed the cycle and metabolically active but not dividing. And G1 is our checkpoint, the alkylating agent like the cyclophosphamide axon G1. S is our synthesis, MTX, 5-fluorouracil, cytarabine, hydroxyurea. They will act on this phase. And G2 is our gap phase. This is our post replication repair. And the bleomycin acts on the G2. And with respect to M, so this vincristine as well as the taxanes like the paclitaxel, docetaxel, they will act on the M phase, on the mitosis phase. So Z0, resting, no division. G1, this is for the growth and preparation. S for the DNA replication. G2 is for the checkpoint and preparation for mitosis, and M itself is the mitosis and the cytokines. So remember, S phase, all the anti-metabolites, MTX, 5-fluorouracil, cytarabine and the hydroxyurea. And M phase, vinca alkaloid like the vincristine as well as the taxane. And G2, bleomycin.
A 65-year-old man presents to the emergency department with a persistent cough, hemoptysis, and unintentional weight loss over the past 3 months. He has a 40-pack year smoking history, and a recent chest x-ray showed a mass in the right upper lobe. Investigations reveal a high calcium level. What is the most likely histological type of lung carcinoma in this patient?
Squamous cell carcinoma.
So this is our paraneoplastic lung condition, and in every diet, in your every part 1 exam from the paraneoplastic lung cancer, you will at least get 1 question, or in some of the diets there are even 2 or 3 question. So what are the conditions that are associated with squamous? What are the conditions they are associated with the small cell lung cancer?
small cell associated with the antidiuretic hormone واكتوبك ACTH اكتوبك Cushing syndrome.
So this
Others-
squamous cell is associated with the hypercalcemia due to the
Hypercalcemia,
increased
yeah.
release of parathyroid hormone related peptide. Small cell lung cancer, this is related to the endocrine condition or neurological condition like SIADs, Cushing syndrome, Lambert-Eaton myasthenic syndrome, or paraneoplastic cerebellar degeneration. With respect to adenocarcinoma, we remember with the A features: absent smokers, asbestos exposure. Bronchial carcinoid, this is classically seen in the younger patient, typically presenting with the bronchial obstruction or recurrent hemoptysis. If you go for the bronchoscopy, they will reveal the cherry red type of lesions. So this chart is very important. And we have also from the post medicine, paraneoplastic. So increased release of PTAs, parathyroid hormone related peptide, leading to hypercalcemia. This is classically seen in case of squamous cell lung cancer. There can also be associated clubbing or hypertrophic pulmonary osteoarthropathy. HPO also related to the gynecomastia, and usually the endocrine condition like ACTH or SIADs or LEMS, these are related to the small cell lung cancer. So in most of the cases, either there should be hypercalcemia, or there should be SIADs, or there should be Cushing syndrome. These three comes most frequently in the exam. So next is our LEMS. So non-metastatic paramalignant manifestation of the small cell lung carcinoma. So most frequently the LEMS, ADs or ectopic ACTs, these three comes more frequently. Other than this, you can also remember polymer. Okay, no need to remember, just memorize these three: LEMS, SIADs, and the Cushing syndrome. They are commonly associated with the small cell lung cancer. So adenocarcinoma, this is most commonly seen in the non-smoker, asbestos exposure female patient, and this is usually peripheral. Carcinoid tumor, young patient, bronchial obstruction, hemoptysis, cherry red type of lesion. And since this is related to the carcinoid syndrome, there should be flushing, diarrhea, there can be wheezing. Large cell carcinoma is also peripheral, and small cell lung carcinoma, this is central. There should be rapid progression. This is related to the either endocrine or neurological condition. And with respect to the smoking is most commonly related to both small cell lung cancer as well as the squamous cell lung carcinoma. So depending on the paraneoplastic features, you will differentiate. Squamous cell SCC is strongly associated with the smoking, typically presents as a centrally located mass, although it can also occur in the upper lobes. It is often linked with the symptoms such as cough, hemoptysis, weight loss. The patient's significant smoking history, hypercalcemia, and the presence of a mass in the right upper lobe along with the clinical presentation makes SCC the most likely diagnosis. And adenocarcinoma, absent smokers, asbestos exposure, it would be peripheral. And small cell, this is also central. This is related to smoking. This is related to either SIADs or Cushing or LEMS. Okay, next.
A 41-year-old man presents to the emergency department with a 2-week history of swelling in his legs and frothy urine. He has multiple sexual partners, but no significant past medical history, and denies any new medications. Lab investigations reveal heavy proteinuria, hypoalbuminemia, and hyperlipidemia. What's the most likely underlying cause of his condition?
Hepatitis B infection.
Yes.
Also, most likely diagnosis.
most likely diagnosed membranous nephropathy.
Yes, very good. This is our nephrotic syndrome, and with respect to the sexual partner, so this is pointing towards mostly it can be either a hepatitis B infection or HIV, and the hepatitis B for us, this is commonly related to the membranous nephropathy. Membranous glomerulonephritis is commonly associated with the chronic infection such as hepatitis B in the setting of multiple sexual partners. This condition often presents with the nephrotic syndrome, which includes heavy proteinuria, hypoalbuminemia, hyperlipidemia. Consistent with the patient presentation, hepatitis B can lead to immune complex deposition in the glomeruli, causing the characteristic changes in the MGN. Diagnosis is typically confirmed by the serological testing for hepatitis B, and renal biopsy will show the subepithelial immune deposit. So deposition of subepithelial immune deposit will give rise to which type of appearance?
Spike.
It will give to which type of appearance?
Spike and dome appearance.
Dome and spike.
It will give rise to the spike and dome appearance.
Dome and spike appearance.
Yeah, it will give rise to the spike and dome appearance. And subendothelial deposition, this occurs in which condition? Membranoproliferative or mesangiocapillary. This will be found in, and that will give rise to the tram track appearance. Okay, so don't get confused. So in case of membranoproliferative or mesangiocapillary, especially in type 1 variant related to mostly cryoglobulinemia, there would be subendothelial deposition giving rise to the tram track appearance. And in case of membranous, commonly related to malignancy or hepatitis B, there would be subepithelial deposition giving rise to the spike and dome appearance. And in this question, the original recall, it was a little bit different. Membranous.
Sorry for interruption. The treatment of idiopathic membranous is stepwise, while non-idiopathic, it's 2C, right?
Yes, yes. Combination of 2C. Don't tell it as non-idiopathic. It's simply you should term it as a secondary, or you should term it as the typical variant. Okay, and another one is idiopathic. Okay. Try this question.
I think membranous caused its DM for only 3 years. It's not enough to cause DM nephropathy.
So is it
I
nephrotic?
think an acute interstitial nephritis. لأن في blood وفي protein.
Which drug is so acute interstitial nephritis? Will it causes nephrotic presentation or nephritic presentation?
Nephritic.
Acute interstitial nephritis will comes up with the nephritic presentation, and here we are getting the nephrotic presentation. So this is our membranous nephropathy.
Membranes, okay.
Yeah,
Doctor, here we are seeing that there is blood is 1+, so isn't it nephritic?
No. Blood one plus is acceptable. You need to have nephronephritic or nephritic. Okay, there is purely nephrotic presentation. There is purely nephritic presentation. There is also nephronephritic presentation. So if there is isolated protein 3+ or 4+, blood is 1+, up to 1+ is considered as an acceptable. So this is our nephrotic syndrome. Alternatively, if the blood is 3+ or 4+, protein is 1+, this is purely nephritic presentation. And if the blood is 2+ or 3+, and protein is also 2+ or 3+, This is nephrotic presentation.
Okay.
So we are having the nephrotic syndrome, bilateral pedal edema up to knees, blood 1+. So heavy proteinuria with mild hematuria, not necessarily indicating the diabetic nephropathy. We are also having the hypoalbuminemia and the ACR criteria pointing towards the massive proteinuria. So this is our membranous nephropathy. Membranous nephropathy is one of the most common cause of nephrotic syndrome in the elderly. Typical features: heavy proteinuria, edema, hypoalbuminemia, usually no advanced diabetes, can be idiopathic, can be secondary to drugs or autoimmune disease or malignancy or infection. And patient will have massive proteinuria, hypoalbuminemia, and the edema. Everything is supporting in favor of the nephrotic syndrome. And the AIN will have the nephritic presentation, and they should be the classically fever, rash, eosinophiluria.
So, doctor, why not? It is DM nephropathy. Why it is not DM? Because of the time period.
Yes, three years.
Number one is the time period, and another one is that in case of diabetic nephropathy, usually there should be poor glycemic control, right? There should be poor glycemic control, but here you can see there is only 48. And also the diabetic nephropathy, this usually start with the microscopic proteinuria followed by the overt proteinuria, and the nephrotic presentation is less commonly seen in case of diabetic nephropathy. So at least there should be long-standing diabetes with the poor glycemic control. Here we are having the almost a good glycemic control, excluding the diabetic nephropathy or DM with nephropathy.
Okay, thank you.
Okay, next one.
A 65-year-old woman presents to the emergency department with new onset fatigue and night sweats. On examination, she has enlarged non-tender lymph nodes in her neck and axillae. A biopsy reveals diffuse large B-cell lymphoma. She started on a chemotherapy regimen plus Rituximab therapy. What is the mechanism of action of Rituximab?
CD20.
CD20.
So mode of action of Rituximab,
Binding
CD20
CD20 positive cell.
and
CD20.
And this
CD20.
Rituximab is most commonly used in the management of Hodgkin's lymphoma or non-Hodgkin's
Rheumatoid
lymphoma
arthritis.
as a part of the R-CHOP regimen. So R for Rituximab and CHOP for cyclophosphamide, doxorubicin, vincristine, and the prednisolone. So this is one of the monoclonal antibody which will specifically target it against the CD20. And remember very carefully, this CD20, this is present both on pre-B and the mature B lymphocyte. This CD20, this is not present both on plasma cell or stem cell. This is present on the B lymphocyte. It can be immature, it can be mature. So they will specifically target the CD20 antigen on the B cell, B lymphocyte, and they will induces the cellular death by the CDC, complement dependent cytotoxicity, or ADCC, antibody dependent cellular toxicity. And usually the plasma cell lacks the CD20. So the immunoglobulin production, it would be relatively spared. So Rituximab, they will act on the CD20 acting on the B lymphocyte. So which groups of drug causes BCR, ABL, tyrosine kinase inhibition?
Imitinib.
So we are having the imatinib, we are having the dasatinib, and the nintedanib. Nintedanib is used in the management of IBF. And imatinib and dasatinib, these two drugs are used
in chronic myeloid leukemia.
These two drugs are used in the treatment of CML or in case of ALL associated with the BCR-ABL translocation. Which drugs causes inhibition of dihydrofolate reductase?
Methotrexate.
Yes, very good. This is our MTX, methotrexate. Inhibition of dihydrofolate reductase, and thymidylate
Inhibitor.
synthesis. Which groups of drugs are the interleukin-2 receptor blockade?
Calcineurin inhibitors.
Yes, very good. These are the calcineurin inhibitors. What are the calcineurin inhibitors?
Cyclosporine.
Famous.
Cyclosporine.
Cyclosporine. One is the cyclosporine, another one is the tacrolimus. Other than
Tacrolimus.
cyclosporine, tacrolimus, there can be the daclizumab or basilixumab, and all the interleukin-2 inhibitors or all the calcineurin inhibitors, they are classically used for the transplant rejection prophylaxis.
Post-transplant rejection prophylaxis, yes.
And VEGF, vascular endothelial growth factor inhibition.
For Rituximab,
Bevacizumab.
Bevacizumab.
Yes, very good.
Bevacizumab.
Ranibizumab, and there is another third drug I can't recall at
For-
this moment. And
For retinal hemorrhage.
trastuzumab, mode of action, it
FP
acts on which receptor?
Trastuzumab
receptor.
for
HER2 receptor, the-
new receptor.
Yes, this HER2 receptor is also known as the mu receptor. This is our trastuzumab. And cetuximab. Cetuximab acts on
Cetuximab.
the EGFR, endothelial growth factor receptor. It will cetuximab acts on the EGFR. And alemtuzumab. Alemtuzumab is used in multiple sclerosis. Alemtuzumab is used in CLL. It will act on the CD52. Okay, CD52.
52.
Okay. So rituximab, a chimeric monoclonal antibody, works by binding to CD20, a surface transmembrane protein marker, which is found on the surface of beta lymphocyte. This binding leads to cell lysis through the mechanism, such as this is our ADCC or CDC. Rituximab is therefore effective in treating B-cell lymphoma and other diseases involving the B-cell. Remember, only the B lymphocyte. This targeted action helps reducing the number of malignant B-cell in condition like in case of diffuse large B-cell lymphoma. And BCR-ABL, the tyrosine kinase inhibitor like imatinib, dasatinib, nintedanib. This is our MTX. This is calcineurin inhibitor, cyclosporine, tacrolimus, basiliximab, daclizumab, and this is our bevacizumab and the ranibizumab. Okay, next.
A 65-year-old man presents to his GP with a 6-month history of progressive shortness of breath on exertion and a dry cough. He has a history of working in the construction industry for over 30 years and retired 10 years ago. On examination, there is digital clubbing and basilar end inspiratory crackles. What is the most likely diagnosis?
Listosis, I think.
It's idiopathic pulmonary fibrosis.
So these two are the confusing. These two are the closer ones. So it can be either IPF or it can be the asbestosis. So we are having the occupational history. Construction workers, retired 10 years ago,
National asbestosis.
and there was 30 years exposure. So the symptoms are beginning following the exposure. So this is typically related to the occupational lung disease. So most likely this is our asbestos related lung disease known as the asbestosis. And patient is having the features of exertional dyspnea, dry cough. So this exertional dyspnea as well as the dry cough, it can also be found in case of IPF, and usually the digital clubbing and the bibasal end inspiratory crackles. So these are the hallmark features of pulmonary fibrosis, which can again occurs both in IPF as well as the asbestosis. In case of IPF, there should be no occupational exposure. There should be no occupational history. So this asbestosis, this is our pneumoconiosis from the inhaled asbestos fibers, ultimately leading to the diffuse pulmonary interstitial fibrosis. So that's why all the features are also identical with the idiopathic pulmonary fibrosis, and depending on the time course, symptoms developing decades after the exposure, this is pointing towards the asbestosis. And in case of asbestosis, what should be the usually this type of patient with the asbestosis, they usually comes up with the bibasal crackles, also known as the velcro like crackles, and also this digital clubbing is common. And if you go for the radiology, there can be also associated pleural plaque, or in advanced condition they can ultimately turn into the mesothelioma as well as the lung carcinoma, especially this is amplified by the smoking. So COPD, in case of COPD, there should be history of the smoking, productive cough, wheezing, as well as the hyperinflated chest. And in case of IPF, so IPF also can lead to this type of features: progressive breathlessness, dry cough, meaning the 3C: cough, clubbing, and the crackers. But here we are clearly given the history of the asbestos exposure, pointing towards the occupational exposure. So in your Mrcp exam, whenever they will give you pictures of 3C plus occupational exposure, you should always consider it as an pneumoconiosis before considering it as an idiopathic variant. And in case of lung cancer, there should be features of malignancy, and in case of TB, there should be other associated systemic features like the fever, night sweat, as well as the weight loss. And classically, it will involve the upper lobe, and there can be features of cavitation. So construction or shepherd, this is related to the asbestos exposure leading to the pulmonary fibrosis, and there should be bibasal velcro crackles as well as the clubbing. So asbestosis, in case of asbestosis, there should be features of interstitial lung disease plus history of exposure. In case of IPF, there should be features of interstitial lung disease without exposure. Asbestosis is a pneumoconiosis caused by the inhaled asbestos fiber. It typically affects individual with a history of the occupational exposure, such as construction workers. The disease is characterized by progressive dyspnea on exertion, dry cough on physical examination findings like digital clubbing, bibasal and inspiratory crackers. The latency period between exposure and symptom onset can be several decades, consistent with this patient history of the retiring 10 years ago. So IPF will have the 3C features without occupational exposure. And in the original recall, it was a different type of scenario. Let me show you this one now. Okay, try this one.
I think أنا مازال pulmonary fibrosis correct answer.
So is it simple cold workers pneumoconiosis, or is it massive pulmonary fibrosis?
Simple cold workers pneumoconiosis, I think.
I think stage 3 it is massive pulmonary fibrosis.
So this is our massive pulmonary fibrosis, since there is the bilateral dense mass on the upper zone. Okay. In case of simple cold workers pneumoconiosis, there will be just a nodular opacity. Okay, but whenever there is dense mass, whenever there is dense fibrosis, whenever there is large fibrosis, this is our massive pulmonary fibrosis. In case of simple cold workers pneumoconiosis, there should be just the nodules or something like that, simple coin-shaped lesion. But whenever dense mass is there, whenever there is widespread consolidation, this is considered as whenever there is a diffuse fibrotic pattern, this is our massive pulmonary fibrosis. So here are the occupational lung disease. So this chart is also important. So in case of asbestosis, so at first you need to look at the exposure or occupation, like the shipyard construction or insulation or roofing. In this one is frequently given, the related to the shipyard construction. There should be diffuse interstitial pulmonary fibrosis. There should be features of 3C: cough, crackles, clubbing on chest x-ray, lower zone fibrosis, pleural plaque, and there is increased chance of mesothelioma, bronchogenic carcinoma, and silicosis, either mining or sandblasting or stone cutting, and there will be classically eggshell calcification, and they will involves the upper lobe, and this silicosis also increases the chance of tuberculosis, as the silicone impairs the macrophage. In case of co-workers pneumoconiosis, there will be progressive massive fibrosis, and there should be predominantly upper lobe opacity. And the berylliosis is related to the aerospace nuclear industry. So asbestosis, lower lobe, pleural plaque, mesothelioma, silicosis, upper lobe, TB risk, egg cell calcification. This is the pathognomonic feature. And co-workers pneumoconiosis, upper lobe fibrosis, core pulmonale, berylliosis, sarcoid like the granuloma or hilar, limb adenopathy. So whenever occupational history is there, you should always consider it as a pneumoconiosis before considering it as an IPF. Okay, next.
A 34-year-old woman presents to her GP with a recurring rash on her left cheek. The rash is erythematous, scaly, and sometimes itchy. She reports that it gets worse with sun exposure and improves when she stays indoors. What is the most likely cause of her symptoms?
So most likely cause of her symptoms or diagnosis?
It's a lead.
So this is our DLE, discoid lupus erythematosus, and DLE is the cutaneous manifestation of SLE.
Obviously.
Also, DLE leads to scarring alopecia or non-scarring alopecia.
Scarring.
So what are the causes of scarring alopecia?
Scarring alopecia, discoid lupus erythematosus.
So what are the other causes of scarring alopecia?
Psoriasis.
And trauma, psoriasis.
Till the important
infection.
causes, not unimportant. That okay.
Lichen planus.
Show you. You need to memorize the
Your
important
Honor.
causes. Okay. So with respect to scarring alopecia means there should be destruction of the hair follicle, number one. And non-scarring means there should be preservation of the hair follicle. With respect to scarring alopecia, the DLA is the most important. Another one is the lichen planus or untreated tinea capitis. And the SLE leads to the non-scarring alopecia. Remember it. SLE leads to non-scarring alopecia. DLE leads to scarring alopecia. And with respect to non-scarring, the alopecia areata, this is the most important one. So alopecia areata leads to the non-scarring alopecia, or it can be due to trichotillomania, or it can be due to the telogen effluvium or male pattern baldness. You can remember either one. So scarring, DLE, lichen planus, untreated tinea capitis. So this is our 34-year-old woman. So this is young adult, and usually the autoimmune disease, this is more frequently seen in the female patient, and patient is having the erythematous scaly, recurrent, and sometimes itchy rash. And the distribution is within the cheeks as well as the sun exposed areas. So this photosensitivity, meaning the rash worsening with sun exposure, improving indoor, this is one of the hallmark features of lupus related skin disease. And this is usually chronic and recurrent in nature, pointing towards the discoid lupus erythematosus. And this is not the acute dermatitis. So this is one of the subtype. This is one of the subtype of the cutaneous lupus that will only affect the skin. There should be no systemic involvement unless the DLA is progressed towards the SLE, and usually there should be well-defined erythematous scaly plaques, usually occurring on the sun-exposed areas like in the face or in the scalp or in the ears, and it can heal with the atrophic scarring or hypopigmentation or alopecia if this is untreated. And also the photosensitivity. Photosensitivity is a classic discriminating clue in case of lupus related skin disease. And to differentiate DLE from the SLE, the DLE is simply confined to dermatological presentation, simply confined to skin. And in case of SLE, there should be systemic features like renal, CNS, serositis, cytopenia, as well as related to the ANA or anti-double-stranded DNA positivity. How to
Corticosteroid.
Topical steroid. Topical steroid first line.
Yes, we'll
Second
be
line
starting with the
hydroxychloroquine.
topical steroid. If there is no response to topical steroid, what should be the
Hydroxychloroquine.
second step?
Hydroxychloroquine.
Yes, you should treat the patient similar to SLE. You should switch on to the hydroxychloroquine. And with respect to the seborrheic dermatitis, so this is classically associated with which conditions?
HIV.
Parkinson's disease.
Parkinson.
So number one is the HIV, another one is the Parkinson's disease.
Parkinson.
This seborrheic dermatitis, you can simply remember it as a dandruff disease. So
Yes.
if this is related to the HIV, so they will give you a scenario of a young patient, usually traveling towards the country of sexual promiscuity. And if this is an elderly patient with the movement disorder, you will consider it as a Parkinson's, as a linkage. So how to treat a case of seborrheic dermatitis?
Anti-dandruff shampoo.
Topical ketoconazole. Topical antifungal is most commonly used.
Topical
Acne rosacea is also very important for the exam. So what should be the features of acne rosacea?
telangiectasia.
Yes, very good. There should be
Pustular.
telangiectasia. So dry skin, increased facial flushing or telangiectasia, and the erythema will affect the cheeks and the nasolabial fold. And this point is the main differentiating point. In case of SLE or in case of DLE, the nasolabial fold would be spared, but in case of rosacea, it would be involved. And usually there is pustular rash around the nose. And also with respect to the treatment of acne rosacea, different types of guideline is there. One of them is mentioned in the past medicine, that is based on mild to moderate as well as the severe. But in the exam, usually the stepwise treatment comes frequently, so you need to memorize the stepwise treatment. So step 1 would be topical metronidazole, followed by topical azelaic acid, followed by other topical antibiotics with the exception of these two drugs, followed by oral antibiotics, followed by oral retinoid. So you'll be following this guideline, and you will skip the guideline that is given in the past medicine. DLE is a chronic dermatological condition characterized by well-defined scaly plaques that can occur in the sun-exposed areas, such as in the face. It often presents with photosensitivity, meaning it worsens upon the exposure to sunlight, which aligns with the patient's report of exacerbation following the sun exposure. Improvement indoors. DLE lesions are typically chronic and may scar if untreated, which explains the recurrent nature of this omens, rash, and rosacea. So they should be flushing or telangiectasia, and usually involves the central face. It will involve the nasolabial fold. And this is our dandruff disease. And in case of tinea facie, there should be unilateral involvement, coming up with the annular presentation. And in the original recall, it was something different. So try this one.
SLA.
I think in SLE يعني.
SLE.
Oh yes, very good. This is our SLE. We are having the anti-Smith positivity, although the CCPNAN is negative, but this is highly specific for SLE. We are also having the skin involvement. We are also having the joint involvement. So this is our SLE. So this is our SLE. So anti-Smith antibodies are highly specific for SLE and they're considered a diagnostic marker. While ANA is typically positive in SLE, its absence does not rule out the disease. Anti-Smith is considered a more specific marker for SLE than the ANA. And the anti-CCP negative, this is mainly related to the rheumatoid arthritis, and it also carries the poor prognostic factors and related to the aggressive joint destruction. So this is our SLE. And I guess there is a chart. Okay. Also, you need to memorize the similar condition. Like in case of DLE, there should be erythematous, well-defined, scaly papule, and the classical feature would be the photosensitivity. In case of SLE, there should be malar rash, also known as the butterfly rash, and there should be systemic features. There should be systemic involvement. In case of rosacea, there should be classical telangiectasia. Along with telangiectasia, there can be flushing, papule or pustule, and it will involve the nasolabial fold. In case of rosacea, remember there should be no scaling, and this is usually worsened following the alcohol or the spicy food. In case of seborrheic dermatitis, classically associated with either HIV or Parkinson's disease, there should be greasy yellowish scale, especially on the upper chest or in the facial zone, and there should be no photosensitivity. And in case of tinea facie, meaning the dermatophyte infection, this is related to the fungal infection. So there should be annular scaly erythematous type of lesion with the central clearing. So photosensitive rash with scarring, consider it as an DLE with no systemic involvement. Malar rash plus systemic involvement, this is our SLE. Central flushing, telangiectasia, this is our acne rosacea. Greasy scaly on the sebaceous zone plus HIV or Parkinson's disease, this is our seborrheic dermatitis. Annular rash with the central clearing, this is our tinea infection. Okay, next.
A 32-year-old woman presents to the GP with a 1-week history of a swollen tender lymph node in her right axilla and a low-grade fever. She reports being scratched by her new kitten 3 weeks ago. On examination, there is a 2-centimeter non-fluctuant lymph node with erythematous overlying skin. What is the most likely causative microorganism?
Disease,
scratch fever.
Cartonella or Bartonella henseli. And Pasteurella multocida, this is found in case of dog bite. So how to
Dog
treat a
bite.
case of cat stress disease in case of immunocompetent patient?
I think
Choice of treatment?
Mac macrolide.
No.
No, I think
Immunocompetent.
No
Okay.
need treatment in
Yes,
immune
very good.
competent
No need to go
patient.
for the treatment.
no
And
need
in
treatment.
immunocompromised,
macrolide.
Amoxicillin.
not macrolide.
Mm,
C for C. Go for ciprofloxacin, okay? C for cat.
ciprofloxacin.
C for cat. C for Cautonella or Bartonella. C for compromised. C for ciprofloxacin. And in case of competent,
Ciprofloxacin.
no need to go for the treatment. So everything is related to C. Cat, Cautonella, Bartonella, compromised, ciprofloxacin. And how to treat a case of dog bite or human bite?
Co-amoxicillin.
So first line would be the co-amoxicillin. And if there is any penicillin sensitivity, then what should be the next step?
Doxycycline.
So the first line would be co-amoxicillin. So co-amoxicillin, this is the first line treatment in case of dog bite, in case of human bite, in case of diabetic foot ulcer. And if there is so in case of dog bite, if there is penicillin allergy, then go for doxymetro
Doxycycline,
combination.
flagy.
Doxymetro combination. Okay, you need to go for combination of doxycycline plus metronidazole. If there is penicillin allergy plus pregnant, go for azithromycin plus metronidazole. And if this is a resistant case or life-threatening condition, go for combination of 2C, clindamycin plus ciprofloxacin.
Clindamycin.
Sorry, sir. Sorry, sir. There is like a patient with diabetic foot and also allergic to penicillin. So, what would be the best choice of antibiotic? I mean,
So the patient is non-pregnant or pregnant.
non-pregnant
So in case
with
of
diabetic foot.
in case of non-pregnant, simply go for you can also go for doxymetro combination. You can go for if this is non-pregnant. Okay, if this is non-pregnant, because both of them can be given orally.
So it would be the same algorithm for all, like dog bite, human bite, and diabetic foot.
No. The only the first line co-amoxicillin. This is same for everything. Okay. This is the algorithm for the dog bite. This is not the algorithm for human bite. This is not the algorithm for the diabetic foot ulcer. This is simply the algorithm for the dog bite. I just mentioned because the co-amoxicillin is the first line in all the three conditions. Okay, and this algorithm is exclusively for the dog bite management, depending on the contraindicating factors. Okay, depending on the contraindicating factors, you need to choose.
All right.
Also, Bartonella hanseli is the causative agent of cat scratch disease, which is typically transmitted through the scratches or bites from the kittens or cat. The condition often presents with the non-tender papule at the inoculation site, which then recedes as a localized lymphadenopathy near the scratch site. Systemic symptoms may include low-grade fever, malaise, fatigue. Diagnosis is often clinical, supported by a history of cat exposure, characteristic lymphadenopathy, and treatment is usually supportive. And Francisella tularensis, tularemia, multisida, dog bite, aureus, this is our bacterial skin infection. And this streptococcus pyogenes, this falls under the group A, streptococcus, which usually leads to the impetigo or erysipelas or cellulitis. Okay, next.
A 35-year-old woman presents to her GP with a 3-week history of neck pain, fatigue, and fever. On examination, she has a tender, diffusely enlarged thyroid gland, and her thyroid function tests show suppressed TSH with elevated free T4 levels. Which of the following is the best management for this patient?
NSAIDs.
Diagnosis?
Subacute thyroiditis.
Yes, this is our subacute thyroiditis, also known as the dequervance thyroiditis. So we need to go for the symptomatic management. So this is our queries. Subacute thyroiditis. Also, in case of subacute thyroiditis or dequerfence thyroiditis, there should be reduced global uptake. Patient will come up with the features of thyrotoxicosis with the tender goiter, and we need to go for the, and it usually follows the viral infection. So initially there would be thyrotoxicosis followed by the hypothyroidism. So this is one of the subacute thyroiditis. This is one of the inflammatory condition, and the tender diffusely enlarged thyroid, this is the hallmark features of subacute thyroiditis. And with respect to the thyroid function test, initially there should be thyrotoxic phase, suppressed TSH, elevated FT4. This is due to the release of preformed hormone. This is not due to the increased synthesis, and usually most commonly this is the post-viral. So there would be destruction of the thyroid follicle, which will lead to the release of the preformed T3 or T4, ultimately leading to the transient hyperthyroidism followed by euthyroid, then hypothyroid before the recovery. And for the management, for the pain and inflammation, you need to start with the NSAIDs, no response, or if there is severe pain, then you should go for the corticosteroid. And if there is severe symptoms of thyrotoxicosis like tachycardia or palpitation, then you can also add the beta blocker. So is there any role of anti-thyroid drugs like carbimazole or propylthiouracil in case of subacute thyroiditis, thyrotoxic phase? Yes or no?
No.
I don't think so.
So remember, carbimazole or propylthiouracil, these are contraindicated even in the thyrotoxic phase of subacute thyroiditis, because this is not something related to the increased synthesis. This is due to the preformed release. So if you use the anti-thyroid drug, there is further chance of developing the hypothyroidism. You can go for the thyroid replacement in the form of levothyroxine. So tender thyroid, systemic inflammation, transient thyrotoxicosis, consider it as a subacute thyroiditis or dequerfence thyroiditis. The first line would be NSAIDs. In refractory case, go for the corticosteroid. If there is severe symptoms of thyrotoxicosis, then you can add beta blocker as an adjunctive therapy. Always avoid carbimazole or propylthiouracil. Also, NSAIDs are the first line agent used for the pain management in subacute thyroiditis, a self-limiting condition often triggered by a viral infection. Patients commonly present with neck pain, fever, and symptoms of hyperthyroid due to the release of produced thyroid hormones into circulation. As the gland becomes inflamed, NSAIDs are effective in managing both pain and inflammation without affecting the thyroid hormone synthesis. And this propranolol, this is indicated whenever there is very severe symptoms of thyrotoxicosis. And in the original recall, it was a completely different question. And it was very difficult for the candidates. So okay, 1 minute. I think this is not the one. Yes. Okay, try this one.
I think C, technetium.
Technetium 99. Scan.
Yes, very good. This is our technetium scanning of the thyroid gland. Diagnosis here.
Subacute.
Subacute thyroiditis.
So we need to, this is our subacute thyroiditis or dequervous thyroiditis, and we need to go for the technetium. And usually the FNSA, this is usually used whenever there is suspicion for the thyroid nodule or a cancer. So this scan is used to assess the functional status of the thyroid gland. In subacute thyroiditis, the scan typically reveals low or no uptake of the radiolevel iodine or technetium due to inflammation or glandular damage. There should be globally reduced uptake. This helps to confirm the diagnosis as opposed to other types of thyroid disease such as Graves' disease where there is increased uptake. The scan provides functional information about the thyroid and can confirm the diagnosis, differentiating it from the other causes of thyroid dysfunction like the Graves' disease. So with respect to the hyperthyroidism, so we have the toxic multinodular goiter, we have Graves' disease, we have subacute thyroiditis, especially the early thyrotoxic phases, and there are other conditions like the silent or painless thyroiditis, factitious thyrotoxicosis, or stroma ovary, but these three are less important. So our main focus would be on the Graves' disease, toxic multinodular goiter, as well as the subacute thyroiditis. So which one is the most common cause of hyperthyroidism in the young women? Most common cause of hyperthyroidism in the young women, Graves or toxic or subacute thyroiditis? Which one is most common?
Graves.
Yes, very good. This is the Graves. And also remember the ophthalmological presentation, the ophthalmopathy like exophthalmos as well as the pretibial myxedema. These are the exclusive features of Graves' disease. They won't be found in other conditions. So both eye involvement, skin involvement, they are exclusively seen in case of Graves' disease. And in case of toxic multinodular goiter, so there should be irregular nodular goiter and there should be no eye sign. And in case of subacute thyroiditis, there should be painful tender thyroid, and there should be the viral prodrome like the fever, malaise, and there should be transient thyrotoxicosis, and there should be suppressed TSH, elevated FT4, low radioiodine. So high ESR, tender thyroid, self-limiting condition. First one would be the NSAIDs. So Graves' disease is the only condition that will comes up with the eye or skin findings, ophthalmopathy or pretibial myxedema. Painful condition is the subacute thyroiditis. If there is both low uptake and low thyroglobulin, this is our factitious thyrotoxicosis. The hot nodule would be found in case of toxic adenoma, and elderly patient with multiple irregular nodular goiter. This is our toxic multinodular goiter. If there is features of hyperthyroidism plus pelvic mass, this is our stroma ovary. Okay, next.
A 40-year-old man presents to the GP with involuntary jerky movements and a family history of similar symptoms. Genetic testing reveals a genetic abnormality on chromosome 4. What is the genetic mechanism underlying this condition?
Anticipation.
Most likely diagnosis.
Huntington's disease.
Which one is related to the genetic
I'm sorry,
abnormality on chromosome number 4?
Trinucleotide.
This is our Huntington's
Huntington's
disease.
chorea.
The Huntington's chorea, this is caused by expansion of the CAG repetition on HTT gene located on the chromosome number 4. 4. Okay, this is located on the chromosome number 4. So what is the genetic mechanism for the Huntington's disease?
Trinucleotide expansion.
Yes, this is our trinucleotide repeat expansion. This is our threads. And with respect to the anticipation, so the Huntington's disease, it will exhibit the anticipation, meaning more earlier onset, more severe disease in the successive generation. So this anticipation genetic mechanism, the mechanism is the trinucleotide repeat expansion. And with respect to genetic imprinting, so this is usually seen in case of Prader-Willi syndrome or Angelman syndrome, loss of heterogeneity. So this is the mechanism for the tumor suppressor gene inactivation, which is seen in retinoblastoma as well as the Lynch syndrome. And X-linked inheritance. So X-linked inheritance, this is usually seen in the Duchenne muscular dystrophy, or in case of hemophilia A or B. So what are the other trinucleotide repeat expansion disorder?
Friedreich ataxia.
Myotonic dystrophy and Fragile X syndrome.
Fragile X.
Friedreich ataxia shows threats, yes or no? So here is our
what?
trinucleotide. Where is the trinucleotide? I guess this is in some other slide. Okay, with respect to our Huntington's disease. Huntington. What is the spelling of Huntington's? T-I-N-G-T-O-N. Also, in case of Huntington's disease, there would be CHE repeat expansion on the HTT gene located on the chromosome number 4, and the diagnostic testing would be the molecular genetic testing. Trinucleotide repeat expansion is the most appropriate genetic mechanism underlying Huntington's disease. Huntington's disease is caused by expanded CAG nucleotide repeat on the HTT gene on chromosome number 4, and anticipation, earlier onset, increased severity on the successive generation. Okay, loss of heterogeneity. This is related to the loss of one allelation, and X-linked inheritance are a long list of conditions where the male would be more severely affected. Anticipation. Okay, try this one. This is easier for you.
Anticipation.
Yes, this is our genetic anticipation, more severe onset on an earlier onset on a successive generation. And what are the other conditions that exhibit anticipation? Genetic anticipation condition that so the here are some of the core features. So there would be earlier onset, increased severity. They are usually related to the repeat expansion. There can be instability during mitosis and parent of origin effect, meaning the expansion is often more likely or severe depending on whether this is inherited from the mother or from the father. So here are the classical disorder showing the genetic anticipation. Mnemonic is the hungry, fragile, fried by spaghetti. So hungry means Huntington, fragile means fragile X, fried means Frederick ataxia, means myotonic dystrophy, and the one is the spinocerebellar ataxia. So all of them will shows the genetic anticipation. So you need to remember the 5 conditions. Okay, next.
A 34-year-old man from Oman presents to the emergency department with a 7-month history of persistent diarrhea, significant weight loss, night sweats, and abdominal pain. He reports no recent travel outside his home country and has no known food allergies. On examination, there is mild abdominal tenderness without guarding or rebound. Which of the following is the most likely diagnosis?
Intestinal TB.
Most likely diagnosis?
Intestinal tuberculosis.
Yes, very good. So intestinal tuberculosis. So here is the demographic. 34-year-old man from the Oman, and Oman is one of the TB endemic regions. So usually the Indian subcontinent, this is mostly our endemic region, but Oman and as well as the Ireland can also be the endemic. And patient is having the persistent symptoms, persistent diarrhea, weight loss, night sweat, abdominal pain. This points towards the systemic and the chronic inflammatory features. And since the patient is having the mild abdominal tenderness, no peritonism, so this points towards the subacute process, not an acute process. And also this epidemiological origin, like the Oman, this is pointing towards the TB, and this is the good differentiator against the IBD or other chronic causes of diarrhea. So usually in case of intestinal TB, the Mycobacterium tuberculosis, they usually infects the GIT tracts, most commonly the ileocecal region, ultimately leading to chronic diarrhea, abdominal pain, as well as anorexia and the weight loss. And it can mimic the Crohn's disease both clinically as well as the radiologically. Like in case of intestinal TB, there can be bowel wall thickening or strictures, as well as the mesenteric lymph adenopathy. And if we go for the biopsy, we can easily differentiate, because in case of intestinal TB, there should be which type of granuloma, caseating or non-caseating? Yes, very good. There should be non-caseating granuloma along with the acid-fast bacilli. So usually both the clinical presentation as well as the radiological presentation would be similar, both in case of TB as well as in case of Crohn's disease. So in your exam, whenever they are pointing towards an endemic zone, you should consider it as an intestinal TB. And celiac disease, this is more frequently seen in the female patient, coming up with the features of unexplained diarrhea as well as the features of malabsorption. Crohn's disease will also have the similar types of presentation. And in case of Crohn's disease, there should be non-caseating granuloma, and there should be no history related to the endemic zone. And IBS is one of the functional disorder. There should be either chronic diarrhea or constipation or mixed variant. And the night sweat, significant weight loss, this is ruling out the IBS. And Whipple's disease, this is one of the multisystemic involvement. There can be arthritis, there can be neurological features. Mostly all of the systems are involved in case of Whipple's disease. So whenever there is chronic diarrhea, systemic symptoms like night sweat, weight loss, endemic zone, you should consider it as an intestinal TB, and there should be caseating granuloma. And the Crohn's disease is more common in the Western countries, and there should be non-caseating granuloma. intestinal TB should be considered in patients from the regions where the TB is endemic, such as Oman. The chronicity of symptoms, including diarrhea, significant weight loss, night sweat, abdominal pain, aligns with the intestinal TB presentation. Moreover, this condition can mimic other than GI disease, but is supported by the epidemiological context in this patient. Diagnosis typically involves imaging studies like CT scan showing thickening of the bowel wall and confirmatory biopsy revealing the granuloma. And original recall was most probably okay. Let me show you intestinal TB. Try this one. Almost similar.
Adult celiac disease.
Again, it's a,
I think celiac.
no, it's again, it's intestinal TB.
Oh yes, very good. This is our spinal, sorry, not spinal. This is our intestinal tuberculosis. This is our intestinal tuberculosis.
Travel
So
travel
patient
to
is
endemic
also
area.
from the endemic zone, from the Oman. There is systemic presentation as well, and all the features it can be explained by the systemic disease, or it can be explained by the chronic inflammatory conditions. Number one is our recent travel to endemic zone like the Oman, chronic weight loss, abdominal pain. So both are the common symptoms of intestinal TB. Anemia, it can be explained by both chronic infection as well as the malabsorption, which can lead to the iron deficiency anemia commonly seen in intestinal TB. And low calcium, low albumin, these are the non-specific marker for malnutrition, which is also common in case of intestinal TB due to the impaired nutrient absorption. And the raised CRP, this is the inflammation, which is also typical in case of tuberculosis and other infections like the Crohn's disease and the Whipple's disease. So with respect to adult celiac disease, although celiac disease can cause malabsorption and weight loss, this is less likely in this case due to the patient's travel history and lack of specific findings like the anti-transglutaminase antibodies or the villus atrophy on the biopsy. And similar presentation can also be seen in Crohn's disease, but they have clearly mentioned the endemic zone. They have mentioned regarding the Oman. And in case of Whipple's disease, there should be other features like neuro, like joint pain, like the skin pigmentation. And this granulomatous inflammation or caseating necrosis as well as the AFE, these are the confirmatory findings in favor of intestinal tuberculosis. Next.
A 64-year-old woman presents to the ED with a 3-day history of watery diarrhea, abdominal pain, and fever. She was recently discharged from the hospital after undergoing conservative management for an unrelated condition. Stool cultures and tests for common pathogens, including norovirus, are negative. What is the most likely diagnosis?
It is a medication-induced diarrhea. It's a history of
So elderly patient recently hospitalized, and patient is having the watery diarrhea, abdominal pain, fever. So the timing has occurred shortly after the hospital discharge, and the investigation, the stool culture is negative, meaning the norovirus is negative, pointing out from the infectious causes. So usually after hospitalization, if there is watery diarrhea, then usually either antibiotics or PPI or laxatives, or in some cases the chemotherapy or metformin, they are usually commonly related. And usually the antibiotics usually disrupt the gut flora, ultimately pointing towards the Clostridium difficile, or it can be PPI, which alters the gastric pH, ultimately changing the gut flora, and as well as the laxative, metformin, chemotherapy drug. All of them can cause the diarrhea. So most likely this is our medication-induced diarrhea. So in your exam, whenever there is recent hospital discharge followed by diarrhea with negative stool culture, you should always consider it as an drug induced or medication induced diarrhea, unless Clostridium difficile is explicitly mentioned. So Crohn's disease, there would be a chronic course. It will not comes up with the acute 3 days onset, and there would be chronic diarrhea, abdominal pain, weight loss. IBS is the functional disorder, a lactose intolerance, so it will comes up with the bloating, flatulence, as well as the diarrhea after the dairy consumption, and this is not related to the hospital stay. And small bowel bacterial overgrowth, so this is either related to the Sjogren's, this is either related to the systemic sclerosis, or this is commonly seen in the diabetic patient. So hospitalization, following hospitalization, if the stool is negative, patient is having diarrhea, you should always consider it as a medication induced, unless Clostridium difficile is explicitly mentioned. So unmute yourself, please, doctor. Given the patient recent hospitalization and the timing of the symptom onset, medication-induced diarrhea is the most likely diagnosis. Certain medications such as antibiotics or proton pump inhibitors can disrupt the normal gut flora and cause the diarrhea. The absence of common pathogen like norovirus further supports this diagnosis. It is also important to consider recent medication the patient may have been prescribed during her hospital stay, which can lead to the diarrhea as a side effect. And the original recall was something different. This is the difference between Crohn's and intestine. Okay, try this one.
Celiac.
Irritable bowel.
IBS.
Irritable bowel. Celiac disease.
Is it IBS, or is it celiac, or is it Crohn's disease?
I think IBS. But the celiac more, as there is evidence of anemia.
Celiac disease.
This is our celiac disease. This is the celiac disease. So patient is having the history of diarrhea, abdominal pain, bloating, altered bowel habit, and some improvement following the lactose-free diet. Patient is having the features of anemia and the low Mrcp, pointing towards the microcytic anemia. Celiac disease is a chronic autoimmune condition triggered by the gluten ingestion, leading to villous atrophy in the small intestine. This results in malabsorption of the nutrients in the iron, causing microscopic anemia. GI symptoms may include chronic diarrhea, altered bowel habit, bloating, abdominal pain. Lactose intolerance can co-occur because of secondary lactase deficiency from the damaged intestinal mucosa, which explains the partial improvement with the lactose-free diet. So combination of GI symptoms, microscopic anemia, partial lactose sensitivity, it strongly one of the functional disorder. So this is not related to malabsorption, so it will not lead to the features of anemia, especially the microcytic anemia. So here are the differentiating point between the Crohn's disease and the intestinal TB. So Crohn's disease is more common in the Western, and intestinal TB is more common in the Southeast Asia, Middle East, as well as the Africa and the Oman. And with respect to with respect to systemic features like fever, night sweat, weight loss, these are more common in case of TB. Involvement site, so TB ileocecal, and Crohn's disease any part of the GI tract. And histology is the main differentiating point. Caseating in case of TB, non-caseating in case of Crohn's disease. And treatment is also different. Go for anti-TB therapy, and in this case you need to go for the immunosuppressant. So non-caseating Crohn's, caseating plus endemic plus night sweat, tuberculosis, and there will be ileocecal disease. So what are the causes of diarrhea following hospitalization? Causes of diarrhea following hospitalization.
See the membranous colitis.
So we can grossly divide. We can grossly divide as infective, medication induced. Another one is the functional disorder. So with respect to infective, the most common one is the Clostridium difficile, which is classically seen following the antibiotics or other drugs that are commonly related to the Clostridium difficile diarrhea. And other than Clostridium difficile, there can be norovirus, there can be other hospital acquired bacteria like Salmonella, Campylobacter, or E. coli, this variant. And in case of infective, both in case of infective and medication induced, there should be watery diarrhea. And in case of Clostridium difficile, there should be extra features of foul smelling stool, and there should be features of the pseudomembranous colitis. So you should always think of Clostridium difficile whenever there is recent antibiotic use and diarrhea is within weeks of hospital stay, and you should confirm with the stool toxin test known as the CD test. You should detect the CD on the stool, Clostridium difficile toxin on the stool. And in case of medication induced, there should be recent discharge, and there should be negative stool culture. You should consider it as a drug induced. And with respect to medication induced, there can be antibiotics, there can be PPI, there can be laxative, there can be chemotherapy, there can be metformin. Metformin only leads to the bile acid diarrhea. All other formulation leads to the watery diarrhea. And with respect to the functional, it can be IBS, it can be overflow diarrhea, or it can be as a part of the enteral nutrition. And IBS is the diagnosis of exclusion. And usually in your exam, most likely if there is diarrhea after hospitalization, either it would be either they will test you recent antibiotics or drugs, or they will test you regarding the infective Clostridium difficile infection. So just go for the stool testing. If the stool testing is positive for CD, Clostridium difficile, this is our Clostridium difficile diarrhea. If this is negative, then most likely this is our medication induced diarrhea. Okay, next.
A 48-year-old man presents to the emergency department with sudden onset of severe lower back pain radiating to the lateral aspect of his leg and dorsum of his foot, accompanied by weakness in foot dorsiflexion and numbness. On examination, there is decreased strength in the extensor hallucis longus and diminished sensation over the first web space. Which nerve root is most likely affected?
L5.
5.
Oh, so this is our L5 radiculopathy. Which one is the hallmark features of L5 radiculopathy? Hallmark features?
Weakness dorsiflexion.
Yes, this.
and extensor.
History of the sensory loss over the first web space, meaning between the grade 2 and the second 2. This is one of the pathognomonic L5 root involvement. And another hallmark feature would be weakness in foot dorsiflexion and EHL weakness, and sudden severe lower back pain radiating to lateral legs or dorsum of the foot. These are usually the features of classic radiculopathy distribution, and along these features there can also be numbness on the dorsum of the foot. And this L5 largest of the 5 toes, meaning the great toes, there should be weakness of great toe extension, sensory loss over the great toe. So this lumbar 5 has got the motor innervation. The L5, it innervates the tibialis anterior, which is responsible for ankle dorsiflexion, and as well as the EHL, extensor hallucis longus, which is responsible for the big toe extension. So ultimately this type of patient will come up with the features of foot drop. With respect to the sensory innervation, the L5 will suppress the dorsum of the foot as well as the first web space. And so whenever the first web space is mentioned, the first web space numbness is mentioned, plus weakness of the foot dorsiflexion and weakness of the EHL, you should directly jump to the L5 radiculopathy. And with respect to L4, usually this is responsible for the medial leg sensation and reduced knee jerk. And the S1 is related to the plantar flexion weakness, reduced ankle jerk, lateral foot numbness. The L5 nerve root is most likely affected given the clinical presentation. The L5 nerve root innervates the muscle responsible for foot dorsiflexion, meaning this is they are telling about the tibialis anterior and the extensor hallucis longus, and this is responsible for the first big toe extension, which is commonly tested by asking the patient to extend their big toe. Numbness over the first web space is the classic sign of L5 radiculopathy. Okay, next.
A 67-year-old man is referred to the cardiology clinic with worsening shortness of breath and fatigue over the past 3 months. On examination, a large V wave is observed in his jugular venous pressure, and a holosystolic murmur is heard best at the lower left sternal border. What is the most likely underlying cause of his symptom?
Tricuspid regurgitation.
So giant V is related to the tricuspid regurgitation. Giant V into tricuspid regurgitation. Prominent V web on JFEB. This is classically punctures the tricuspid regurgitation, and a right ventricular infarction, it can also lead to the tricuspid regurgitation. Tricuspid valve endocarditis can cause tricuspid regurgitation, which may manifest with a neopansystolic murmur, large V wave, and the features of pulmonary emboli. The Canon V wave or the pathognomonic for right-sided heart failure, which occurs during the infarction of the right ventricles. So this patient has comes up with the features of dyspnea as well as the fatigue, pointing towards the heart failure. And this large V wave, this is the pathognomonic features of tricuspid regurgitation, meaning the right atrial filling during the systole, and the holosystolic murmur at the LLSP, lower left sternal border. This is also the classic auscultation site for tricuspid regurgitation. So whenever you find giant V wave plus pansystolic murmur at LLSP, this is our tricuspid regurgitation until proven otherwise. So what happens in tricuspid regurgitation? There is incompetent tricuspid valve. So ultimately there should be systolic backflow, a systolic backflow of the blood from the right ventricle into the right atrium, and on the JVP you will get the classical large V wave or giant V wave. And if you auscultate, there would be hollow systolic murmur at the LLSP, which would be louder during the inspiration. This is also known as the Carvalho sign. This Carvalho sign, hollow systolic murmur at the LLSP, louder on inspiration. And in case of aortic stenosis, which type of murmur would be found?
Ejection systolic murmur.
Yes, there would be
Radiation to neck.
ejection systolic murmur. It would be best heard on the right upper sternal border. There would be radiation towards the carotid, and this is also associated with a slow rising pulse, narrow pulse pressure, and there can be left ventricular hypertrophy. And HOCM, this is the commonest cause of SCD. Which type of murmur would be found in HOCM? Also the ejection systolic murmur. It should be harsh ejection systolic murmur. It would be best auscultated at the left sternal edge, and it would be accentuated, not accentuated, it would be worsened with the Valsalva maneuver. And with respect to the mitral stenosis, which type of murmur?
Diastolic murmur. Rumbling.
Yes, there would be
murmur.
mid-diastolic rumbling murmur, loud S1 with the opening snap. And in case of pulmonary embolism, a patient will come acutely with the chest pain, shortness of breath, tachycardia, as well as the hypoxia. So giant V wave on JBP plus hollow systolic murmur at LLSP. This is our TR, tricuspid regurgitation. And the apex, hollow systolic murmur located in the apex. This is our mitral regurgitation. And ejection systolic murmur found on the base. This is our aortic stenosis. Tricuspid regurgitation directly involves incompetent of the tricuspid valve, allowing backflow of the blood into the right atrium during the systole. This results in a characteristic murmur and the large V wave visible upon examining the JVP due to the increased volume being pushed backward into the systemic venous system with each ventricular contraction. This backward flow leads to systemic congestion and symptoms such as worsening shortness of breath, fatigue over time, which aptly fits the clinical scenario described. Hence, tricuspid regurgitation is most consistent with both physical examination findings and the patient's presentation. Okay, next.
A 65-year-old man is brought to the emergency department with a history of congestive heart failure and recent worsening dyspnea. He has been taking furosemide for the past 2 weeks. On examination, he is alert, but shows signs of volume depletion. Blood tests reveal hypokalemia and metabolic alkalosis. What is the most likely cause of this patient's metabolic alkalosis?
Diuretic therapy.
So most likely cause of metabolic alkalosis.
Diuretic therapy.
So most likely this is our diuretic therapy. So following the diuretic therapy, which specific pattern of metabolic alkalosis occurs? It has a beautiful name. This is known as loop diuretic induced chloride responsive contraction metabolic alkalosis. Okay, loop diuretic induced chloride responsive chloride responsive contraction metabolic alkalosis. So chloride responsive contraction metabolic alkalosis. So what happens in the diuretics therapy? So let's consider the furosemide, the loop diuretics. So it will causes the salt and water loss. So ultimately there should be ECF volume contraction, ultimately leading to the relative increase in the serum bicarbonate. So since there is volume contraction, there is a real volume contraction due to salt and water loss, which will causes the relative increase in the serum bicarbonate. So for this reason, this is known as the contraction alkalosis. And due to the there will also be the renal angiotensin aldosterone system activation and increased distal sodium delivery, ultimately leading to the enhanced hydrogen and the potassium secretion in the collecting duct, ultimately leading to metabolic alkalosis as well as the hypokalemia. And this hypokalemia, it will maintain the alkalosis. The hydrogen ion, it will shifts into the cell as the potassium leaves, and there should be increased renal ammoniogenesis and the hydrogen secretion. And there will also be the chloride responsive pattern. So often the low serum chloride and urinary chloride can be variable, but usually there should be low serum chloride if the diuretic is recently taken. So it will lead to chloride responsive contraction metabolic alkalosis. And in case of AKI, there should be metabolic acidosis associated with the hyperkalemia. Cone syndrome is also known as primary hyperaldosteronism. So there would be metabolic alkalosis plus hypokalemia, and usually the patient would be hypertensive with the mild volume expansion. They won't be volume depleted, and there should be no diuretic triggering. Inadequate ventilation, so there would be this is respiratory condition. They will lead to the respiratory acidosis. And with respect to the vomiting will lead to the chloride responsive metabolic alkalosis, often with the hypochloremia and the low urinary chloride level. So loop diuretics followed by volume contraction, RAAS activation leading to metabolic alkalosis and hypokalemia. This is our chloride responsive metabolic alkalosis induced by the loop diuretics. Furosemide is a loop diuretics that increases the renal excretion of sodium, chloride, potassium, and water while decreasing the extracellular fluid volume. This leads to the contraction alkalosis as bicarbonate concentration rises in relation to the reduced circulating volume. Additionally, hypokalemia from excessive potassium loss further contributes by driving the hydrogen ion into the cell in exchange for potassium coming out into the plasma. Okay, next.
A 41-year-old woman presents to her GP with fatigue, mouth sores, and hair loss. She has a history of rheumatoid arthritis for which she's been taking new medication for the past 6 months. Blood tests revealed pancytopenia. What is the mechanism of action for the most likely drug causing these symptoms?
That's methotrexate.
So which drug is commonly used in the management of rheumatoid arthritis?
Methotrexate.
Yes, methotrexate. And mode of action of MTX?
Dihydrofolate reductase inhibitor.
Yes, this is our DHFR. Simply you can remember as DHFR, dihydrofolate reductase inhibitor, and the thymidylate synthesis. So DHFR, dihydrofolate reductase. And in order to prevent, you need to go for the folinic, not folinic, as a prevention or prophylaxis, you need to add folic acid. But whenever there is evidence of methotrexate toxicity, whenever there is evidence of myelosuppression, you need to add the active form folinic acid. Methotrexate. Which drug causes the cyclooxygenase inhibition?
NSAIDs.
Is the NSAIDs. NSAIDs will causes the cyclooxygenase inhibition. So calcineurin inhibitors we have already mentioned. Also with respect to the THFR, so this NTX, they usually inhibits the THFR, ultimately blocks the formation of the tetrahydrofolate, and this will prevent the purine and thymidylate synthesis, ultimately halting the DNA synthesis in the rapidly dividing cell. And this is most commonly used in rheumatoid arthritis. And with respect to the adverse effect, you need to remember the myelosuppression leading to pancytopenia. It can also lead to mucositis, alopecia, as well as the pulmonary fibrosis. So you should always co-prescribe folic acid whenever you're planning to go for administration of MTX, and whenever there is features of methotrexate toxicity or myelosuppression, you need to add the active form, the folinic acid 5 mg. DNA intercalation,
Dactylomycin.
usually the anthracycline derivatives like the doxorubicin and the daunorubicin, they are related to the DNA intercalation. TNF alpha inhibition,
Infliximab, adalimumab,
is
etanercept.
the infliximab, adalimumab, etanercept, and there is a golimumab as well. And TNF alpha inhibition causes reactivation of which latent infective condition?
Tuberculosis.
Yes, this is all
Tuberculosis.
TB, latent TB reactivation. Methotrexate inhibits dihydrofolate reductase, an enzyme crucial for the synthesis of tetrahydrofolate. This is necessary for the purine and thymidylate synthesis in rapidly dividing cells such as in bone marrow, mucosal things, hair follicle. The mechanism explains its effectiveness in treating the condition of rheumatoid arthritis by reducing the immune cell proliferation. However, it also accounts for the side effects like pancytopenia, mucositis, alopecia due to the decreased cell turnover. And COX inhibitors. So COX are the COX-1, COX-2 inhibitors, the NSAIDs, and the isolated COX-2 inhibitor are the which drugs? The COX-6.
Celecoxib.
Yeah, the solicopsib, etorcoxib, valdecoxib, rofecoxib, this groups of drugs, and they are interleukin-2, cyclosporin, tacrolimus, and intercalation, doxorubicin, daunorubicin, TNF alpha, infliximab, etanercept, golimumab, adalimumab. And also in the original recall, it was also direct question. They are asked regarding the mechanism of action of MTX. It was the DHFR. Okay, next.
A 25-year-old woman presents to the emergency department with acute onset of chills, fever, back pain, and dark urine shortly after receiving a blood transfusion. On examination, she is tachycardic and hypotensive with a temperature of 38.5. Lab tests reveal hemoglobinuria. What is the most likely cause of her symptoms?
Acute hemolytic transfusion reaction.
Also, this is our acute hemolytic transfusion reaction. So that's, and patient has comes up with the features of fever, chills, back pain, and this back pain, this is the classical, this can be classically explained by the hemolysis due to the renal involvement. Hypotension, tachycardia, these are the features of shock, and the dark urine, meaning the hemoglobinuria. And this hemoglobinuria, this is a feature of intravascular hemolysis. So this is the classic feature of ABO incompatibility, ultimately leading to the acute hemolytic transfusion reaction. In case of ABO incompatibility, this is related to IgM antibody or IgG antibody, IgM or IgG.
IgG.
No, this is related to the IgM antibody. The preformed IgM antibodies, they will activate the complement, ultimately leading to the rapid intravascular hemolysis. So this is our acute hemolytic transfusion reaction. How to differentiate transfusion associated circulatory overload from transfusion related acute lung injury? Trally from the TACO. The main differentiating point. So this is our circulatory overload. So there should be hypertension.
Hypertension.
There should be hypertension, and in case of Trally, there should be hypotension, and this is related to the non-cardiogenic pulmonary edema. So there should be pulmonary infiltration. And in ABO incompatibility, there should be back pain, there should be collapse, there should be features of shock, there can be features of DIC. And also remember this back pain in case of ABO incompatibility, this is classically due to hemolysis due to the renal involvement. And in case of febrile non-hemolytic reaction, there should be just isolated pyrection, no features of shock. So depending on the BP, you can remember whether this is Trally or TACO. Depending on the features of shock, you can differentiate whether this is ABO incompatibility or this is our febrile non-hemolytic reaction. An anaphylactic transfusion reaction, this is classically seen in the IgA deficient patient. So they are the IgA deficient patient, and it will lead to the hypotension, bronchospasm, angioedema, or tachycardia usually within minutes. But there should be no hemoglobinuria. There should be no back pain in case of anaphylactic transfusion reaction. And febrile non-hemolytic, this is usually most common. There should be just isolated fever. There can be chills or mild malaise, but there should be no hemolysis, no hypertension, no hemoglobinuria. And circulatory overload will have the hypertension with features of shortness of breath, pulmonary edema, raised JVP. And this Trally will have the pulmonary infiltration as a part of non-cardiogenic pulmonary edema. So whenever there is ABO mismatch, intravascular hemolysis, hemoglobinuria, hypotension, back pain, this is our acute hemolytic transfusion reaction. Also will comes up with the features of shock. Whenever there is only mild fever, this is febrile non-hemolytic. Whenever there is airway compromisation with urticaria, this is our anaphylaxis. Fluid overload plus hypertension, circulatory overload, acute hypoxic lung injury, pulmonary infiltrate plus hypertension, this is our Trally. Also acute hemolytic transfusion reaction, this is the most likely cause of the patient's symptoms given the timing of our presentation. Following a blood transfusion, acute hemolytic transfusion reaction are often due to ABO incompatibility and can present with the fever, chills, back pain, hemoglobinuria, and hemolysis. This reaction can lead to severe complications such as DIC, renal failure, and shock. The patient's tachycardia, hypertension, and hemoglobinuria are the classic findings in this condition. Okay, next.
A 35-year-old woman presents to her GP to discuss the possibility of donating a kidney to her brother who has end-stage renal disease and is on the transplant waiting list. What is the probability that she's a complete human leukocyte antigen match with her brother?
What should be the chance of HLA matching in case of siblings?
25.
And in case of identical twins?
100%.
100% in case of identical twins. And in case of siblings, there is so 25% identical HLA match in case of siblings, and in case of identical twin, it should be 100%. So 25%. So the siblings have a 25% chance of a complete HLA match. Is parent has 2 sets of HLA gene, passes 1 set to each children. Since there are 4 possible combination of this gene, children can inherit their 1 in 4, meaning 25%, and 100% in case of identical twin. Okay, the last one.
Sent to the emergency department with episodes of palpitations and dizziness. Her ECG shows a prolonged QT interval. Which of the following medications is most likely to have caused this finding?
Amiodarone.
Immuodron.
So drugs causing the prolonged QT interval. So this is our amiodarone. Amiodarone is our class 3 anti-arrhythmic drugs. This is our potassium channel blockers, and it will prolong the phase 3 of the repolarization, ultimately leading to the prolonged QT interval. And other than prolonged QT interval, what are the other adverse effects of amiodarone?
Amiodarone-induced thyroiditis, then
Bluish
Causes-
discoloration,
It causes
Bluish-
hypo or hyper.
both it can cause.
Yes, very
Both
good. It
of
can
them.
cause both AIH or it can cause AIT. Amiodarone-induced hypothyroidism or amiodarone-induced thyrotoxicosis. It can cause pulmonary fibrosis. It can cause hepatotoxicity. It can cause corneal deposition. It can cause photosensitivity. It can cause the skin discoloration. So you should always need to monitor the liver function test, the thyroid function test, the chest X-ray, as well as the ECG. And this disoxin will lead to the shortening of the QT interval. It will cause the scoped ST depression, also known as the reverse tick sign. It can also lead to the arrhythmia. Regarding the reverse tick sign, the ECG won't come in your part 1. You'll learn in your part 2. The furosemide, this is loop diuretics. It will lead to hypokalemia. It will lead to hypomagnesemia, which can secondarily lead to QT prolongation, but this is not the primary medication leading to QT prolongation. That's why we have gone for the amiodarone. And lisinopril is the inhibitor, angiotensin receptor blocker. They will lead to the hyperkalemia. And metoprolol, this is our beta blocker. It will slows down the AV conduction and ultimately leading to either bradycardia or AV block. So what are the drugs that lead to the QT prolongation? This is important for the exam. Drugs leading to QT prolongation. What are the drugs?
Macrolide.
Antibiotics such as macrolides, fluoroquinolones, and then we have antifungals, antipsychotics.
Yes,
and
very
then
good. So number 1 are the antibiotics, especially the macrolide and the fluoroquinolones. With respect to the antipsychotics, most commonly are the haloperidol. With respect to antidepressant, we have both SSRI as well as the tricyclic antidepressant. And with respect to the antiarrhythmics, it can be caused by amiodarone. It can also be caused by sotalol, quinidine, and the procainamide. Okay, there was one doctor who asked a question similar to us. Okay, any further question from anyone? Cotrimoxazole, it can be given. It can be given in case of listeria meningitis, but most commonly we follow the regimen of gentamicin plus amoxicillin or ampicillin. This regimen is frequently given. Amiodarone is an antiarrhythmic medication which is known to prolong the QT interval. It affects the cardiac action potential by blocking the potassium channel, which delays the repolarization and extend the duration of the action potential. This can increase the risk of Tourette's T-pointis, a potentially life-threatening arrhythmia. Patient on amiodarone should have regular ECG monitoring to assess for QT prolongation and other potential side effects. Disoxin will cause the shortening. So how to treat a case of Tourette's T-pointis polymorphicity? Choice of treatment?
Magnesium, so IV magnesium sulfate.
Yes, we need to go for the IV magnesium. Torsets. Also patient with the, so also the methadone, it can also lead to the QT prolongation, amitriptyline, and there are other one inherited condition known as the Jervell-Lenz-Nielsen syndrome, coming up with the long QT syndrome, sensory neural deafness. It can also lead to prolonged QT interval. So patient with a long QT syndrome develops syncope and palpitation as a result of polymorphic ventricular tachycardia, known as the Torsades de Pointes. Choice of treatment would be IV magnesium. So IV magnesium, this is indicated, this is used for the pulseless Torsades de Pointes. You need to go for immediate defibrillation. And in case of hemodynamically unstable patient, you need to go for the synchronized DC cardioversion. If you can't remember all the three, for part 1, just remember you need to go for IV magnesium. There should be prolonged QT interval, irregular wide QRS complex. So any further question? If there is no question, I'll be concluding here, and hopefully inshallah I will restart again from tomorrow same time.
Doctor, can you tell us about the broad complex tachycardia?
You mean the I mean the differential diagnosis of the algorithm?
Yes.
So if you consider the broad complex tachycardia, so broad complex tachycardia, it can be either ventricular tachycardia or it can be supraventricular tachycardia with the aberrant conduction, or it can be the pre-excited tachycardia, and usually these three are most important. Usually the ventricular tachycardia is the most common, and this is more commonly related to the structural heart disease. And with respect to SVT with aberrant conduction, so aberrant conduction means there should be either atrial fibrillation or atrial flutter associated with the bundle branch block. Okay, and another one is the pre-excited tachycardia. Pre-excited tachycardia means atrial fibrillation associated with the pre-excited phenomenon like the old Parkinson-White syndrome. So with respect to broad complex tachycardia, mostly this is VT, or it can be SVT with aberrant conduction, or it can be the pre-excited tachycardia. And there is a long list of criteria, the factors which will suggest the VT rather than SVT with aberrant conduction. So I mean those extreme axis deviation, AV dissociation, capture or fusion beat, positive or negative QRS concordance, and also the very broad QRS. So you need to memorize all the criteria. If any of the criteria fulfills, this is regarded as VT. This is not regarded as SVT with aberrant conduction. If the criteria does not fulfill, then you need to look whether this is SVT with aberrant conduction or if this is pre-excited tachycardia. If there is associated WPW syndrome, this is our pre-excited tachycardia. If there is associated bundle branch block, this is our SVT with the aberrant conduction. Okay. And also with respect, if you consider the management, so for all types of tachyarrhythmia, whether this is brady or whether this is tachyarrhythmia, if the patient is unstable means if there is any features of SSC, shock, syncope, chest pain, cardiac failure, if any of the adverse features is there, you need to immediately go for the synchronized DC cardioversion. So this is for the unstable patient. I mean this is whenever there is any adverse sign. In case If the patient is stable, then if this is the probable VT, then you will be starting with the IV amiodarone. Alternatively, you can also go for procainamide or lidocaine. And if this is SVT with or without aberrant conduction, then you should go for the IV adenosine. Okay, is it clear? Anything else?
Thank you, doctor.
Okay, doctor, thank you. So I guess you're from Pakistan, right? Dr. Umar Sohi.
Yeah.
Okay. Thank you. Okay, we'll be concluding here. Okay, Allah Hafiz.
Allah Hafiz, doctor.